Good morning, everybody. We're going to go ahead and get started. My name is Shelley Brannon. I'm the pediatric nurse educator here at Providence, and we are so lucky to have Erica Miller from Seattle Children's today and her colleagues, who she will introduce in just a moment, to present pediatric mental health for us so we can serve our community and our kids a little bit better. So welcome, and thank you so much.
All right, good morning, everybody. I manage, see, now I'm all nervous because the camera's there. People are fine, cameras are I manage our psych consult services, so our mental health team in the emergency room, nursing staff that go around and support providers and nursing staff with challenging kids and behavior. So for today, Hero and Laura, as they're both psych nurses, mental health evaluators in the emergency room, do case management, and really have been a part of kind of our continuous improvement on how do we figure out how to serve these kids. And really, I hope you can leave here today with, if we sent every single nurse and doc to school to be a psychiatrist or a psych nurse, the need is still so great, right? We can't train enough mental health people to take care of all the kids who need it. So my goal here is that you leave with some tangible, concrete things that you can do, and that you have a little less hesitation or fear of screwing up or doing something bad. Really, these kids are just needing an ear, some listening, some empathy, some compassion, and being able to feel like you have enough kind of tools in your toolbox to try things out when challenges come your way. So want today to be interactive, so please ask questions as we go. If something doesn't sit right with you, or if you want information, please just let us know. We're happy to talk it through between the three of us. We can probably answer most of your questions, and then making sure that it really applies to your day-to-day work here. So are there burning questions or things? I know 4 hours is a long time. We'll take a break at 10. If you want to take a break before that, just help yourself and go. Are there burning things that any of you have that you really want to ensure that you hear about today, or really, yeah?
Anything you know about the PIT, parent-initiated treatment?
Fabulous.
How it applies to us, ER versus when they actually get up to the inpatient floor?
Yep, we can do that. Okay. Anything else? All right, so we are going to go through, this is kind of the basic agenda for today, the need out there and why you're feeling such kind of a shift. I'll definitely say a shift. We've been doing this for almost 18 years, and it's definitely been a shift in the past 3-4-ish years of the kids coming in the door. The words we use: evaluation and treatment. We can talk about parent-initiated treatment, how we send kids home, and then understanding and managing aggression. So, can you guys see that okay? This is from 2016. This stats always lag in years, but suicide in our kids and teens has become the second leading cause of death. When we started doing suicide prevention training, it was the third leading cause of death. So it has shifted just in the most recent time. This is for Washington. We are overall, all ages, 22nd in the country, so we have a higher rate of death than nationally. It's 15% versus nationally 13. 8th leading cause of death overall in Washington. First leading cause of death for kids 10 to 14. And second leading cause ages 15 to 34. And nearly 5 times as many people die by suicide in Washington annually than by homicide. So if you just think of a classroom, right? That's always the thing that gets me in my gut, is if I think about a classroom and 1 of 5 of those kids is struggling with a mental health issue and a third of the class is thinking about dying by suicide, it makes it all of our jobs, including teachers, including parents. Yeah. Did you have a, yeah?
Oh, yeah, to add to the thing to go over, anything you can tell us about transgender or
Yeah.
emerging sexualities, we find that a lot.
Yep, definitely higher at risk, for sure. This is a little older, but this is by county. So I think just as a state, as a whole, you know, King County is fairly resource rich in mental health services compared to the rest of the counties. So services get less and less as you go farther out in the state, right? As well as access to firearms also increases as you go farther out in the state. So some of the counties that they don't have enough to report, and one would say that our this is only reported deaths by suicide, so other accidental deaths that could be by suicide aren't necessarily accounted for, so this is underreported. Leading cause of deaths, of course, firearms is number 1, just because there's little ability to save somebody from that action, right? And then suffocation, poisoning, we see probably the most of in the hospital, right? These are the kids that you're able to treat and be able to help. So just thinking around mental health stigma and people coming to healthcare for care, and this is definitely something that we all, even those of us in mental health, have to be really conscientious about changing our language around it, right? Of not saying things like they completed suicide or it was a successful suicide, right? That those words imply that there was some kind of success or achievement around the act. And we want to shift our language to died by suicide or a suicide attempt. The word around committed suicide actually comes from when suicide was against the law and it was a criminal act. So again, trying to take away the stigma of you're breaking the law versus somebody really being in deep pain and seeking help. And then getting away from words like cutting or manipulative or attention seeking, that we, any kind of self-harm we want to refer to as either suicidal self-injurious behavior or non-suicidal self-injurious behavior, right? That there's some, especially teen girls who self-harm either by cutting or other kinds of acts that that is an act of coping versus an act of trying to die in that moment. So, and it's just, I think it's interesting now to pay attention to these words, and as there are celebrity deaths in the news, that you really pick up on the words that really kind of add to the shame of these celebrities dying by suicide, and just the message that it might convey to somebody who's struggling with that. So, of course, suicide is not just, a symptom of whatever psychopathology is kind of driving that, or maladaptive coping. So, common diagnoses in kids that we are seeing coming into the emergency rooms is suicidal ideation and suicide attempts, right? And it's definitely, we'll go more into it later, but definitely a certain level of contagion factor, a certain level of influence of social media, higher stress in kids, and I would say less coping in parents. That really, we haven't seen the parents of the kids that are coming in are also struggling with these issues as well, and so the ability to support the kid in the moment isn't there. A lot of depression and anxiety, definitely an increase that we are seeing. And then you'll see your either first manic break or a drug-induced psychosis or a drug-induced mania. Definitely young adult is that age where these things tend to appear. And then we see kids with aggression, disruptive behavior, conduct disorder, and autism with aggression, right? That you're not admitting kids to a psych unit for autism. It's the severity of the behaviors around that diagnosis. All right, so mental health evaluation, really briefly, you are evaluating for risk of suicide, imminent risk to self or others, imminent risk for violence to others, grave disability, so that captures your kids with psychosis or even autism who aren't able to go to school, aren't showering, aren't eating, aren't communicating in the way that they need to be able to function for their kind of developmental level. Mental health is one that the philosophy really behind mental health is that the behavior change comes in the community and over time, and so that there's pros and cons of hospitalization, and so there is really a push to ensure that people have used their outpatient resources, have tried everything available before utilizing an inpatient psych bed. And so I think that can be a super hard conversation with families, especially when services don't seem sufficient for that kid and family, or that there's barriers to whatever it is of that family getting to those services. And it's a challenge to navigate within the county systems or to be able to advocate for a higher level of service maybe that kids would need. So in our state, comparatively to many states on the East Coast, have partial hospitalization, step-down, intensive outpatient services, and that's not something that's readily available to our kids and families. And so really the choices for them are weekly or maybe bi-weekly therapy if they're lucky, or inpatient. We just don't have the breadth of services that many other states have available. And then looking at the diagnostic criteria behind that. So always trying to, again, look at kids are running, living in the community with these diagnoses, right, of depression or anxiety, and it's really the exacerbation of symptoms that leads them to unsafe behaviors that get them into the hospital. So I think this is helpful just to really appreciate the severity of what gets kids in the hospital. And I know in our emergency room, most families come in expecting admission. And it is a finessed conversation to help them shift their expectations around the acuity that they're perceiving in their child and what an inpatient stay would benefit them and how they can utilize outpatient better. So inpatient criteria is really imminent risk for self or others. Inpatient stays are really short. They're 5 to 7 days. It's really a safe container for that crisis. There's very little behavior change that families leave with the same kid that they went in with, so that there's really not a significant change where they're leaving with a totally new kid out of a psych unit. So I think that's important for families to understand, is that it's safe, the crisis can die down, that it's a safe place for kids to be until they get to the other side of that, but then the work continues to happen on an outpatient basis over time. So kids that have an active psychiatric disorder that can be more efficiently treated, so those are like your new psychosis, new mania, that really getting them in and getting them on antipsychotics quickly. Docs can ramp up those meds faster on the inpatient side than outpatient. Acute or serious deterioration from the patient's baseline to fulfill age-appropriate responsibility, that's going to look different for each kid, right? So there was a 6-year-old this week who they're still not sure what's going on, but really normal functioning 6-year-old kiddo that totally tanked and had unable to eat, unable to toilet, odd behaviors, maybe some OCD, like obsessive compulsive behaviors, but it was really a dramatic change in, let's say, 10 to 14 days, right? That's a significant, where versus you might have I think this is the hardest population, kids with autism who are already not functioning at a great baseline, but it's really being able to show that they've had an acute change in that baseline. So it's really, I think for those families, it's really hard to say, like, this is exhausting and this is an exhausting kid to parent and he needs a lot of help and support and attentiveness, and this is his baseline, and a couple days in a psych unit isn't going to significantly change the outcome for this kiddo. And then I think eating disorders as well. A lot of our eating disorders get managed on a medical basis, get rehydrated, get their heart rate up, that only when they're 15% below ideal body weight do they qualify for a stay in a psych unit. So we are fortunate in this state to have more residential or eating disorder specific places, and they'll have different admission criteria, but to go to a psych unit for an eating disorder, you have to be pretty low and kind of on death's door, right? That their heart rates are 30, 35, they're emaciated, they have pressure ulcers from, but being able to go to places like Center for Discovery or Pediatric Recovery Center, that there are more treatment options available for those guys. So admission to any psych unit, and I think you guys have Smoky Point that's close. I think beds are a crisis in this state, even with Smoky Point being added, even with Tacoma General adding a kids unit, that when there are no beds, there are no beds. And you know, there's 40 kids waiting in emergency rooms across the state, that we are really able to see that our trends follow the school year. So staff up on your finals weeks, get a breather around the holidays, that our volumes and acuity totally go with the school schedule. And so we've actually taken that strategy to shift our staffing in ways so that we have more people available depending on who's on break and who has finals. But we're really looking at criteria. Do they meet imminent risk for self or others? Can they go voluntary? So there's another slide with more, right?
You can talk about it now and answer the question about it.
That in this state, 13 and older can consent for their own mental health care, which means that they can also decline that need. So for that reason, kids under 13, their parents admit them, it's considered a voluntary option or voluntary admission. Parent-initiated treatment is an ability when kids meet psychiatric acuity for admission and another physician agrees with that determination. Parents can sign them in against their will, And when they are signed in under parent-initiated treatment to a psych unit, then that case gets reviewed at several junctures by a different DSHS kind of review board to ensure that there's still that psychiatric acuity to be holding the kid against their will, and that their rights aren't being unfairly taken away. So that really works for the majority of our teenage admissions. It's been super helpful in the times that we didn't have PIT years ago when we had to involuntarily detain all these kids. We spent a ridiculous amount of time down at Harborview at court, and it was really traumatizing for these kids. So if you were involuntarily detained, the county mental health professional, they're the DCR now, I'm getting used to that, comes and actually takes away their legal rights, and then they have to go to court at 72 hours and 14 days. And in our area, they go down to Harborview and are in the mix with every other person who is being involuntarily detained, adults as well, and it's a pretty traumatizing experience for kids. So parent-initiated treatment has been fabulous. So how it applies to your setting, kids are not necessarily, PIT only applies to a psych unit, but you are still able to hold kids for admission to a psychiatric unit as long as they continue to meet acuity, right? That there is no safe discharge, that you are holding them for essentially a higher level of care. Does that make sense?
Does that mean that we're able to hold kids against their own will as long as parents say that they want them to?
Yes.
Because you've determined that they already meet acuity for an inpatient psych admission. So if they don't meet acuity for an inpatient psych admission, then none of this even applies.
Sure.
Because your first step is, do they meet criteria?
Right. Our practice in the past has been for kids who are older, if they are involuntary, to have the DCR now come and evaluate them and involuntarily hold them if they meet their criteria. If not, then we have not held them based on parents' will. Because kids have the right to refuse.
Kids have a right to refuse, but you can still meet just because they've been involuntarily detained doesn't mean, so those are two different branches. So are you saying that?
We have not been holding kids under PIT because we are not a psych institution.
Not holding them in the ED? Or not holding them in the medical units?
Not admitting them while awaiting inpatient treatment. It's essentially sending them home from the ER.
You send them home from the ER if there's not a bed.
If a child who is 13 or over does not want to be admitted, and we feel they meet inpatient criteria, we will get the DCR to come, regardless of what parents want.
Interesting.
And then if the DCR does not detain them, we essentially feel like we have to send them home because a PIT doesn't apply in our institution. So if that's incorrect, then we can certainly change our practice, but that.
Well, if the DCR says they don't meet criteria, they don't meet criteria.
Right.
So when you make that call though to the county, they don't ask you if you've considered PIT?
Our understanding is that we cannot use PIT to detain kids.
Yes, PIT is for outpatient safety. So PIT is parent-initiated treatment with information. They get that week. We go to children's. Mostly children. We wait for an edge.
Yeah. That's just interesting to me that when you make that referral to the DCR, that they don't say.
Because our DCRs, if we called them out if we didn't have a bed, they're sitting in the ED, we think they meet criteria, we call the DCR out. If the kid or family is willing to agree to PIT when they get to the psych unit, our DCRs won't detain them and won't hold them.
Because they don't need to. Because
Right.
we have PIT, right? Does that make sense? So why would you take that pool of money from the county for these outlier cases? The amount of times that we actually get an involuntary detainment is pretty rare. So I would imagine that in your institution, you're constantly calling them out.
We have about 20% ITAs, I would say.
That's
we don't have kids
astronomical.
with PIT.
Yeah, we're on from 3 in the inpatient here, and we always got told we never do pits, and then on 3 we had a pit all of a sudden, and so we're always never clear. We get different answers depending on who we ask about whether we can pit, whether we can.
I think it's probably important to go back to your risk management legal team, and be clear about what's in your policy, right?
We're not
I
a
think-
psych
yeah.
facility.
Right.
I mean, we don't have an inpatient psych unit.
Correct.
They're on the pit, on the unit, and then we try to transfer them when they do get it bad. We've had the ambulances refuse to take them because they say you don't do pits, we can't restrain them, we're not taking them.
Oh my god.
That's not okay.
Because we'll hold them in the ED until we have a bed.
Yeah,
Because we know that we're admitting under PIT once a bed opens.
Yeah,
Well-
but once they come up to peds,
Yeah.
if they've said that to them down there and the parents believe they're on a pit, when they're up on this floor, we don't do that.
Yeah, we have.
Do you want us to email you a copy of our PIT form, our PIT agreement, our legal PIT form?
But I thought the law
Well-
does not require non-psych facilities to hold them. Because the law, the non-psych facilities, so going back to what the
Yeah.
law says, the non-psych facilities do not have PIT because we don't have
Right.
the ability to provide the treatment.
True. But you also have the ability to hold somebody for a safe discharge.
Which is the same thing that we do for ITAs.
Yeah.
It's just you're skipping a step in between the attempt to get a kiddo on an ITA versus using the PIT and transferring them once you find a bed.
So, I mean, there isn't anything wrong with having these kids ITA'd, and you get access to a different level of services by calling out the DCR and seeing if they have diversion beds or any other ways that they can escalate in their system to provide services. So it's not necessarily bad to ITA these kids. I would think if we're taking one we'll usually switch it. Like if the kid and the family are willing to do PIT when they get to the psych unit at Children's, we'll drop the ITA and flip them to PIT. So if you need to do that for your institution to have them ITA'd in order to hold them, that's fine. I think psych units will try and drop that ITA if possible, if it makes sense for the kid. Because in our experience, most of these, the only time we need an ITA is if we're going to compel meds against.
I was gonna say, you can't force them into the pit.
You can't compel antipsychotics for treatment. You can use medications for agitation in an emergency, but you can't compel, let's say, somebody to take Zyprexa every day for their psychosis or mania. So those are the essentially the only kids. Or residential beds are pitiful in this state, and so one of the only ways to really get fast track to residential is on an ITA. Those kids jump the line.
Sorry,
Yeah.
I'm not like the only one
No,
asking
that's
questions.
good.
Sorry. So, because they'll come up to our unit and they say they're on a pit, which then we're told we don't do, but then we call the DCR because either the kid wants to leave or they won't take any meds, and then the DCRs won't come out to evaluate them because they said they're on a pit.
Correct.
How do we get them
So you're stuck.
Yeah, it's
on
a revolving
whole
door,
day?
yeah, it's an
I mean,
issue
if the
for us.
DCR is telling you that they recognize it as a PIT, they said it. I mean, you know what I mean? Like,
But then how do we detain them if they're really not?
Yeah. Yeah, we've had 3 cases now where we've gotten quote hits up on 3A when we're told we don't do hits.
And who is saying
who's saying you don't?
how is
Risk management. And social work.
I mean, yeah.
And social work, because they will say they'll notify the parents in ED about a PIT, and they sign something that says they're aware that they can do that.
Which we never
But
did.
Everett, like Prob does not do them because we're not a psych hospital. So then they're telling parents you can do a PIT, and the parents think that when the kids come up, they're on one.
Sounds like you need to get risk management and social work
Well,
on the
but
same
we
room.
tell the parents they can have a
the
PIT. A PIT exists, that's what we're required by law
when
to
they get to us?
inform parents. But we say we don't do it. These are the facilities that do it.
Right, but you're holding them to move them to another facility, correct?
Is that what you're doing?
Yes, they're awaiting an inpatient psych bed on our unit.
So,
Yes.
that's what you're
This
doing.
is just the transitional phase. We're responsible for keeping them safe until the bed is found.
Right.
But then if the kid is then above 13 and refuses treatment and wants to go home, you have to call the DCR to detain them.
Yes.
That's
Yes.
Yes.
No, that's what the pit is for.
Change
The pit takes the
needless to
place
say,
of
we
the
have
ITA.
But we have consistently
Well-
gotten a message from our risk management that we cannot use PIT to detain kids.
So risk management needs to talk to
Well,
legal.
fortunately, risk management is in the room right
Yeah.
now.
Yeah, well, they're just, it sounds like anything else, it seems to be different on a different day of the week. Because yes, we have had occurrences where pits have come upstairs, which should
Regardless, I
never.
think we do a good job in taking care of them.
Yeah.
If there's imminent harm, we don't let them go whether they're 13-year-old or not. If there's imminent harm and we have some issues, we'll get them out.
Absolutely. And that's the bottom line.
Yeah. We're gonna get them in some place.
It's just a way to make it easier for everyone, right? It's just a way to streamline
It's
it.
not the inpatient setting.
But we are, the general consensus here is correct, right? That we do not do PITs here. in the
Correct.
Right, we do not have, we give them information on the period of treatment and where they can go and we'll
It's the medical
So if they would want to keep
And
someone
then the
in,
ambulance
they
won't
would have
take
to
them to the right
We
bed.
need to know what ambulances are doing.
You're missing the purpose,
Yeah.
point of the pit. The purpose of the pit is to replace ITA. You're not utilizing PIT for the purpose that it's meant for, is to avoid the adjudication system of ITA and to keep those kiddos out of that legal system that is meant for adults. And if you're not utilizing that system, then we're kind of violating the rights of the parents and the children to keep them safe. It sounds to me
Well-
like that we need that form that you're already utilizing so that we can get that system set up here to better meet the needs of our patients, to keep our kiddos safe.
No, that's a bigger issue.
Yeah.
So,
Create a psych unit.
that's a whole
Right.
bigger
But
issue.
if we get that form, then we can forward that to legal and have them.
Okay, but this has
identify.
already been addressed through Kim Williams and legal and patient safety, so it needs to go through patient safety.
Right.
We're not gonna be the ones to.
Well, and there's also there is another PIT bill being processed by the state around expanding what PIT covers, including potentially outpatient options. So that has not gone into law. They're getting more, but there's definitely a group of parents who are trying to push through the state a wider expansion of the PIT definition to help mandate kids to go to outpatient treatment and those kinds of things. So there will be more to come on that. So, and our risk management is one of my best friends at work, so definitely some of these kids or the increasing amount of adults who think it's cool to come to a children's hospital for their psych care, that I call them when I get stuck and get their consultation on these gray / ever-changing, evolving kinds of issues. So, okay, in our state, Children's has 41 beds. Smoky Point hovers around 25. They kind of flex, as far as I know, depending on their adult volume. Fairfax also flexes, but they have around 18. Two Rivers in Yakima is an unlocked facility. They have 16. Kitsap has 10 over in Bremerton, and they really reserve those for kids in that county, mostly. And then Tacoma General / Multi-Care, they added 26 beds, but they don't have the staffing for them yet. They're working on getting nurses and psychiatrists. So I think they run about 10 as well. So definitely we are one of the last states in the nation for ratio of need to available beds. There are more beds adult beds being built in like Pierce, Thurston County, somewhere down there, but I haven't heard of any more kid beds coming.
Like the Smoky Point, they don't take kids under the age of 13, right?
Correct. So the under 13 has to come to Children's. Nonverbal, developmental delay have to come to us. any kind of medical acuity, so our dialysis kids, our diabetic kids, our heart transplant kids, all come to us. And you will be frustrated, perhaps, that you have a very nice, healthy 16-year-old suicidal female, and we will prioritize the kids under 12, kids with autism first before that nice teenager. And that's just the way the nice teenagers have to go to the other facilities so that we can make space for the younger kids and kids that can't go anywhere else. Just so everybody's on the same page, an inpatient psych stay, no matter where you go, whether it's Children's or Fairfax or Smoky Point. It can be 3, 5, 7 days. It's really acute stabilization. The psychiatrists or the clinicians at those units are having to have daily conversations with the insurance about whether they still need acuity. And the day that that child says, oh yeah, I'm feeling safe now. That boyfriend that I had an overdose because he broke up with me, he wasn't worth it anyways. I'm like this new guy. We're moving on. We're discharging.
I met somebody at the psych facility this year.
They met somebody. Yes.
Aim higher, teens. Aim higher. That's what I tell my kids. Aim higher.
And kids who have had collusion with each other, any kind of suicide pact, or my boyfriend got admitted and now I want to be admitted, we'll try and divert those kids to other psych units. So you can work on you. We don't need all that drama right now. They're seeing a psychiatrist daily. They're getting the diagnosis clarified. For some of these kids, the diagnosis is really going to declare itself over time. And so for some of it, it's having families sit with the unknown or the gray again of not quite sure. It could be this. It could be this. But we really have to kind of play it out as they grow and develop, and somebody's going to have to keep an eyeball on them over time. They can start medication changes and advice to the outpatient prescriber on how to either titrate something off or ramp something up, and perhaps some things to think about don't go well in the future. If there's a rapid medication change that's needed, that's really done well on a psych unit, that we can titrate a med down and ramp one up at the same time and have close observation to make sure that goes okay for the kiddo. I think many of our kids are not discharged to psychiatrists, and so making sure everybody knows about the PAL line. It's for primary care physicians or providers who are prescribing psych meds, and it's 9 to 5. You can get phone consultation on managing a kid with mental health issues. They also have ability to get resources and stuff. So many times pediatricians or primary care providers are taking these kids back and being the main prescriber with that PAL line as a support to them. A lot of the milieu therapy on a psych unit is really around skill building, and that again, it's not days and days of therapy and individual Freudian figuring out where all this has come from in the past, right? It's, you have depression, you have anxiety, you're not coping well. How can we, lots of people in the world have these diagnoses and are able to cope and keep themselves safe and out of the hospital. And that's really the focus of the skill building on a psych unit. And that can be being really clear with families about that. I think families sometimes think, oh, they can go and they can have therapy for 3 days and they're gonna come out and have this whole traumatic thing resolved and it's gonna be all better. And that's not the expectation or the reality, that we're really talking to kids about how can you do mindfulness activities when you're having suicidal thoughts? How can you go assertively tell somebody that you need help, right? You know, kids an internalizer and they need help, like just being able to articulate how they're feeling, or coming up with communication strategies maybe with their family. Yeah.
So with kids that are within like the autism population,
Yeah.
how exactly does that work with skills building?
Good question. And
Repetition and pattern. Yeah, it's more like behavioral reinforcement. So no, you're not doing all verbal groups with them. It's really a matter of repetition, hand over hand, kind of, it's almost like a one-to-one aid for them.
Okay.
If they're
So
really
you guys are
severely
doing
low
more like
functioning.
errorless learning and things like that?
Like what?
Like errorless learning, basically. So you're teaching them like hand over hand, these are the things that you need to do when you're in this state.
Yeah, and
And
using PEC schedules, because I've never seen those before, or
Okay.
using kind of augmented tools of communication,
Okay.
right? But it's extinction and giving them a safe place to practice all that, right? So we can walk away and they're in a contained space to do that, where you can't reinforce that at home because
Yeah.
we're running too, right?
Yeah.
And a lot of it is parent education and helping the parent understand what are the kids' triggers, what are the warning signs, when do they need to intervene, what intervention goes with what piece of it,
What stage of aggression?
so that families have really just more insight into a really difficult child at baseline. Yeah, and meds are a big, because a lot of these kids will react differently, and so a safe place to get meds started and really have a close eye for them. The parent education piece is big. I think if you are letting families know that their kiddos go into a psych unit, the parents really need to be involved, and I know that will differ from us. We encourage families to be there 24/7, and they can sleep in their child's room and participate in groups and learn as much as they can. I know Smoky Point and Fairfax, that is not the case, and have very limited visiting hours. I still think it's super important to let parents know that most of this is going to fall on them, right? That they're going to be responsible for the safety proofing of the home, for understanding their child's crisis plan, for being able to implement that crisis plan in the home, and what does the family need to do to gear up to be able to do that, right? Or is it going to be get some sleep while they're boarding on your floors, so that when they come out of the psych unit that they're ready for 24-hour supervision? Is it going home and getting rid of, cleaning out the house of sharps and cleaners and meds and weapons? Is it rallying their community resources so that they can have grandma to watch them after school, or a neighbor, or those kinds of things? So I think encouraging families still when they're in your setting of this is just the start of the journey, and what are the things that you need to do to really be set up for success to take care of your child when they come home. And then again, time to bulk out outpatient support. Since that takes, in our state, I will say the squeaky wheel gets the services. And so I think that's another way that you can be helpful to parents, is really encouraging them to speak up and escalate through the county or through wherever they're receiving services to say, these are the things that I need, and really that support in navigating the mental health system, and to really make all the phone calls, escalate to the ombudsman, escalate to the director of wherever they're receiving services, so that they can get as much support that they need. And again, helping them understand, even if you don't like the supports that you're given, you got to use them and try it. And so how you as a parent can tolerate the therapist that you don't like, or the in-home caseworker that you think is snarky, right? That you have to utilize those outpatient services, and just saying, I don't like that person, I want a new one. There's not a new one to get, right? And I think really helping parents understand, like, we have limited services, you got to use them. How can I help you do that, so that either it works, or that you're able to say, we tried this and we now qualify for a higher level of service. Does that make sense? So, disposition planning after eval, we're really trying to look for the least restrictive alternative. So, again, is it something that with 24-hour supervision, and somebody to walk with from school, home, could this kiddo be safe with a higher level of supervision and involvement. And really ensuring that kids and families, they're really having to, they're making a crisis plan and locking things up at home and trying to figure out how they can best utilize that and really understand it. So we had, I think you had the kid come in that the kid and parent really just couldn't talk to each other. The kiddo didn't need to be in the hospital, but they just were having such a communication barrier that the kiddo wasn't able to use the supports on their crisis plan. Mom wasn't listening. And they came up with an emoji language. Essentially, there was an emoji associated with everything on the crisis plan. It was the kid's idea. But that worked for them, right? That the mom could hear that and see, oh, if I get this one emoji, I know it's an emergency. If I get this other emoji, I can wait 15 minutes to check on him. But it was really being creative in, here's what the kid needs, here's where the parent's at, how can we bridge that to help them be successful and for the parent to meet the kid where they're at and the kid to articulate their needs and get support in those moments. And it's really, I had this semi-frightening conversation with CPS who had a kiddo in their custody, and it was really, yes, if the kiddo is saying, I need attention, the CPS worker was really frustrated because the kiddo was cutting, would say she's needed attention, the CPS worker said, I need to attend to these other things, the kid would go cut, and the caseworker was pissed. And I was like, but she gave you the opportunity. When she asked for attention here, you gotta figure out a way to support that, and it might not be your attention, it might be, but you have to figure out a strategy here at this point when she's asking to have her needs met versus then punishing her or being pissed after she's cut when she attempted to bridge that gap. It's like, okay, lights go on, okay, good. Now you go to the hotel, it was very sad. But moderate level, and again, this is county dependent. If they have stabilization services, we have in Snohomish County, is it CPIT now?
From Compass?
From Compass?
Yes. Mobile.
Has it been helpful?
You have to be forceful to get past the front line.
Okay. So I know that's a recent addition.
What are we talking about? Sorry.
I think it's called CPIT through Compass. It's essentially crisis services, crisis stabilization. It's supposed to be.
I believe it's only for adults.
No.
We've gotten some kids in.
No?
Yeah.
So how does it work? I mean, you get in,
I would say, yeah, how does it work?
you just call them and they come?
Yes.
Well, like we have called, maybe you could speak, we have called the county around other services and they've set up a next day appointment for them to get started with that. So we'll discharge them from the ER that night with a next day appointment with these folks.
So what's interesting about CPIT though is the first couple times I referred to them, I could give them the referral from the emergency department and then kind of pass the baton to them. It's not like Coors and King County where you can actually set up an appointment in the home, but you could refer the family and why and the phone number and they'd be in touch. But then this week when I tried to use them, they didn't want to talk to me, they wanted to talk to the family and the family had to request it. So I'm a little...
And that's what I'm saying, you have to be kind of forceful to get to the actual people.
Right.
Because they have the intake that you have to go through.
Yeah.
So there's a few things that you can utilize it for. You can utilize it for like emergent folks that can get services in the home. I've used them in the clinic setting where I have a voluntary admit and I don't want them to go to the emergency room because we all know how well that process works. So they've come to the clinic, they've done an assessment above and beyond what I've done. They've actually looked for beds, they've helped with that process of transfer to the admission bed, that kind of thing. We've had a patient with he was like 80-something. He had some paranoia, couldn't come in for mental health services, so they gave him services in the home. that kind of thing. But to do in-home services, they have to be voluntary. They have to want services. It's really great for them. But it's through the 211, 411, and you have to say, that's your job. I need to talk to somebody. Otherwise, they'll say, well, you need to do that.
Oh, that's
So this is for
terrible.
What does it stand for, secret? Community.
Community
Should I Google
psychiatric.
it?
I should know this.
Sense of services.
Yeah, I don't know.
And then kids who are
If you look it up
enrolled.
on Compass, you can find it, CPIT, it'll tell you everything that we do.
And then kids who are enrolled with an agency
CPIT.
can access, again, wrapper-wise services, which are more coordinated. Usually there's a parent partner, usually there's some liaisoning, what is that word? I don't know, with the school. But again, I know it's been.
Crisis prevention and intervention teams through Compass Health.
Thank you.
And of course, they have to be Medicaid, and they have to be signed up with Compass first.
I don't know about that. I don't know about that.
But I bet they have to be Medicaid.
They probably have to be Medicaid.
Yeah.
No, they don't.
No?
I don't know if that's true actually.
Okay, good.
The website's a little bare about it too.
Yeah,
So I just call it anyway. Medicaid, yeah.
It's helpful because the children's mental health services on site there's a wait list.
It just says regardless of their funding source. It does not say they have to be.
Great.
But
They don't have to have a previous relationship with company.
it doesn't say, it just says serves adolescents, adults, children who are experiencing behavioral health, mental health, or substance abuse crisis, regardless of their funding source. So,
Is it a different phone number than the Compass one? It's the 1-844-822-7609.
If you call the 211, is it 211 or 411? I mean, yeah, 211. You do that number, you get services covered.
And then more restrictive from that is intensive outpatient or partial hospitalization programs. Again, in this state, you have to have private insurance to access any of those programs currently. Residential, most of those beds are accessed through the involuntary detainment system. We have had kids waiting on our psych unit for over 6 months for those beds. So, and they're ahead of the voluntary ones. Most of them, residential beds are down in Tacoma at Child Study and Treatment Center, and then Pearl Street in Tacoma, and then over in Eastern Washington, there's one. Tamarack? Tamarack. But again, super minimal, and we have had quite a few families take their kids out of state. Consent laws are different, and many private insurances will fund residential programs if they're willing to send their kiddo out of state, which is a sad option. We have talked about this. There are pros and cons about hospitalization, and so again, kids who are boarding a long time, they may be on the other side of crisis and not actually qualify for that bed if they've stabilized in that time while they're boarding. And so I think always reassessing daily if crisis stabilization is still needed, or if the crisis is past, are they in a different spot, is the family in a different spot to use their crisis plan to engage with outpatient services. I know this is also hard, but if kids are already enrolled in services, we're a little annoying, but bugging the outpatient providers to be engaged with care early. I know that I think some of them are so overwhelmed that they are glad that their kid is in the hospital as a provider and can focus on their other cases. But we really try and get those outpatient providers engaged even while the kid is boarding, engaged in what services can they offer to perhaps divert from hospitalization. and continuing to just kind of constantly push on those systems.
So what do you recommend, sorry, this is
Yeah.
a question regarding this happens quite a bit on our unit because we board for long periods of time.
Yeah.
What do you recommend when kids then lose that acuity? Because this is what happens is they're there waiting, they've had an event that has brought them in, usually suicide attempt, and then they're there for so long that then they're not meeting criteria.
They go home.
And this is where we run into the issue with parents not willing to take them home.
And I think
Not finding them safe, now they've never gotten any services other than just been evaluated and been waiting there, we're keeping them safe.
And I think because if they go to a psych unit and they don't have acuity, they're going to be discharged. As they're admitted, they're going to be discharged. That we can't. It might stay a day, but it's not going to. They're not going to get anything from that stay, and so really help. Again, trying to frame for families, even when we have kids boarding, that this is really a safe spot for the crisis to pass. Treatment is really going to come in your crisis prevention planning, right, and keeping your home safe, that the changes, the long-term changes are going to happen over time. And what we want to help them with is staying safe as those changes happen over time. And so that is something that they can do with you all when they're boarding. Crisis plans are not rocket science. They're really basic. You know, kids can start Googling. We'll go through some of them, but kids can start Googling different ways to cope. They can think about, you know, hear from other people, you know, how do you cope when you've had a really awful day? Oh, you don't go cut? Oh, you go talk to a friend? Oh, I haven't tried that before. Like, sometimes you're amazed at, like, how basic things need to be set up for kids to be like, oh, I actually haven't tried that before. Oh, maybe I could go do that. Or that the experience of whatever crisis they went through and now are been being stuck here in the hospital. Sometimes it's like, oh gosh, you know, maybe I can do more next time to avoid this situation. And that sometimes boarding is the intervention, even in our own emergency room. That kid's like, yeah, actually, I'm feeling safe enough. I'll work it out with my mom.
And it's a lot easier to give parents those tools and resources when you've had some very frank conversations with them and the child, even if they're boarding in the ED or boarding on a medical unit, especially if they already have providers. So like I've called providers out to our ED for our boarding kids because I know they have a therapist in the community. Why they don't, like, it always surprises me, like, we did a review over the summer of how many kids come to the emergency room post a suicide attempt or intense suicidal ideation and have a therapist and have a med provider, and you're like, so do you have a rapport with your therapist? And they're like, yeah, they're great. Okay, so you've talked to your therapist about your suicidal thing? Oh no, we don't talk about it. I'm like, so this is why you have a therapist? Let's bring your therapist in, or I put them on speakerphone and I leave the room. And I'm like, so this is exactly why you have a therapist. I understand that you want to talk about the drama stuff that's going on at school, but this is where their expertise is key. And so engaging that provider either on the phone or in the ED or in person with them and bringing the parent in. And many times I've said to the parent, like, because they're so afraid to take their kid home, even when the acuity is not there, like this happened to me on 3 days ago, is really saying, these are the conversations that a skilled therapist is going to have with you. Why don't you try seeing them twice a week for at least the next 2 weeks and have these conversations. We're going to give you like the toddler proofing bit in the suicide world of your home, but these are the conversations you need to start having with your therapist. And then, so maybe putting them on the phone on the medical units with those providers. And if they don't have services, put them on the phone with Compass or your crisis teams and just say, like, we're boarding for a bed, we don't know how soon it'll be, they might move post-crisis, but in the meantime, let's start getting those outpatient resources there, because the crisis plan they're gonna get from our ED looks surprisingly the same as the crisis plan they're gonna get from the PBMU, from the inpatient psych unit. It's the same template. And we'll share those templates, and we brought other templates from like NAMI and other organizations for you to see.
And I think there are cons of hospitalization, right? It's an artificial place, it's keeping, it's a place for the crisis to pass, but there's none of the triggers. It's it's artificial, right? That it's an escape, and that's a lot of what these kids or families are looking for, just a break and respite.
Which is why they then are less acute, because they're there and they don't have the stressors of home and school or whatever precipitated the event.
Yep.
And then the other thing that comes up for us is the kids will say, I'm not suicidal here, but if you send me home.
So
I mean, I've heard it 1,000 times.
For
so
sure.
I heard it once.
For sure.
The key to that conversation is then to say, how do I take that safe feeling or that safe place from the unit and replicate it in your home, especially the ones that have been admitted multiple times or have just left the unit. Our tools are exactly the same. The groups you could probably teach at this point. So what about that unit feels so safe and comforting, and how do I help you take it home? And maybe it's, right, of course you're gonna do better on the inpatient unit. You don't have to worry about food because the food comes to you. You have a laundry service. You don't have the annoying, teachers and peers. You don't have homework.
You have nice
but they're no consequence for not doing it.
22-year-old staff.
Yeah, they're all
who are
25 and
listening
they're always
to-
happy to talk to you. I don't have that. I have a group of 25-year-olds that are always happy to see me and just can't wait for me to do great, right? That's why we aged out of the inpatient unit. We're in the ED now, we're like, we're 40, we can't cheer you on. It's true. We were really cute when we started. Right? But like there was one kid in the ED I had like a year ago who just wanted back on the unit, and we created a comfort room in his home, and mom was like totally on board. You can have, I think she gave him like a walk-in closet as his like comfort room. But like, what about the unit? Is it having access to staff that's always cheering you on? Okay, who in the community can be that person for you? Is it having a safe place like a comfort room? Okay, design it. Let's sit down and do it right now. So, okay, what color would you paint the walls? What would you have there? Think of your 5 senses. What would you smell? What would you listen to it? Right? And so taking whatever those key elements are and showing him how they can have that at home, that's your crisis plan.
And for parents, helping them if they haven't experienced a psych unit before, as lovely as our unit is, it's scary sometimes, right? There's kids with acute psychosis or mania and serious aggression and property destruction, or even just the kids can pick up bad habits from the other kids there, right? That sometimes parents will complain that, oh, my kid wasn't doing self-harm, and now after the psych unit they've started to cut. So really helping parents like weigh, I really equate it to an ICU stay versus, right, that it's intense. You're having to be there all the time, you lose your phone, you're not watching TV, you have very limited clothing, like your life is pretty restricted for that time. And are we at the last resort where that is needed? And sometimes we are, and sometimes families get to the unit and they're like, oh, whoa, no, actually we can do 24-hour supervision. We'll discharge now, thanks. Like, yeah, did you have a question?
As far as providers in the community, I've actually had Compass, 3 different providers, clear their whole day for
Awesome.
kids in crisis. So making that connection early on can be huge for our kids' well-being.
Yeah, way to go for that.
I do feel the need to speak to our psychiatrist. Says he always spells out the research to me that when you look at the children who have had an inpatient stay and those who have not, they are the same at 1 year's follow-up. So
It's not a cure.
no, it is
We
not.
tell them
I
it's
mean,
coping,
so
it's not a cure.
and I think that is why the insurance companies are so more, I don't say difficult, but more specific about inpatient stays now, is really the outcomes are the same. You need to find the work to be done in an outpatient setting.
And I really hope the counties are shifting from being a BHO and having the mental health dollars come to them to being integrated in the managed care plans. And so I actually really hope that these managed care plans will see the value of adding additional services. Right now, there's not a payment structure for Medicaid to pay for partial hospitalization or an intensive outpatient, but those are several $100s a day versus $6,000 a day, right? And so what you can put somebody in the home for every day, 24/7 for $6,000, right? And being able to really, sometimes that would be more beneficial to the kid and family versus a couple days. So currently intensive outpatient, Insight is brand new over in Bellevue. Insight's in Seattle. Fear is in Bellevue.
Yes. Also, I'm available for $6,000 a day. You get all 4 of my family members. We'll all move in.
Fairfax and Smoky Point also have partial hospitalization programs, but again, I think they're mostly insurance payment. So whether they come to a psych unit or get care in an emergency room, really the core things that we want people getting, some psychoeducation, and that's really not necessarily like, why are you depressed, why are you anxious? It's really about kind of the psychoed of how we're coping and how we're living our days, right? Of what are the things, what are the routines set up in your morning that can help set you up for success? What are the triggers that you're gonna encounter during your day that are gonna throw you off or maybe trigger your suicidal thoughts or feelings? And then what are the ways that you're gonna manage those things when you come? A lot of families, we get a big surge of patients right after school and then at bedtime, right? Because it's hard to go to sleep with your unpleasant thoughts and all the bad things that you did, or, all of us, when we've had an awful day, we'll sit and ruminate at bedtime, right? It's hard to fall asleep. And so how can we set up structures and coping for those kids to make it through those times, right? Whether it's music or journaling or being able to talk through the day and kind of let things go, or having some mindfulness so that they can let their thoughts go. And that's really what we're talking about as far as psychoeducation. We'll go into home safety planning or proofing, and then crisis prevention planning.
So evidence-based practice, we threw this in here to talk about why crisis prevention planning works. So there was this wonderful study that talked about whether or not a brief suicide prevention intervention can reduce suicidal behaviors from the ED. And this was not just done in one hospital, it was done across a cohort of hospitals. They received safety planning, so kind of the template that we'll show you today, but they also had a structured telephone follow-up contact just to see if they were using the crisis plan and if they were connected to their outpatient resources. And they found that that did reduce suicidal behavior, and they were more engaged 6 months later. So telephone, the study will explain to you exactly what the call was and how long and extensive it was, but really the key takeaways for us, and we've actually are going to gonna trial something similar to this at Children's, is using creating that crisis plan in the ED, or for you guys the medical unit, and then having someone follow up with them once a week over the phone to say, are you using it? Did you get connected? So they're not going to take ownership of their mental health care, but they're going to kind of do that life coach push to say, are you using it? Do we need to tweak it? And did you connect? Did you share your crisis plan with that outpatient provider? Are you talking about suicide with your outpatient provider? And just kind of giving them that nudge for a period of time showed some really great results. So what's in a crisis prevention plan? So our crisis prevention plan template, NAMIs, right, other hospitals, other providers, there's some basics to all crisis prevention plans, and that's that the patient is able to identify their warning signs, that they're able to identify how they're currently coping, that they start to identify friends and family members who can distract them, right, after they've identified that they're in crisis. And then there's a difference between the people you reach to for distraction versus the people that you go to during the height of your crisis. So especially with teenagers, we're that's great that your best friend can distract you, but when you're in crisis, I need an adult in the room, not your 13-year-old friend that's also, cutting, right? And then that there's a point where those things aren't enough, that's when you go to the emergency room. So we're gonna kind of look through that format now. Can we get to the nanny guide? Do we have internet or no? And we have paper copies if you'd rather grab a paper copy during the break. So what I like about theirs, except that somebody didn't spell check English, is that it's really bold and visual. So this is a 5-step mental health crisis. So you can see it starts with those warning signs, right? And then it gives you examples of what those warning signs can look like, right? Of a crisis. And then if you scroll down, warning signs of suicide, right? And then if you scroll down again, what to do. So I love the do's and don'ts. Like, if someone's thinking about suicide, don't be afraid to talk to them about it. And then it even gives you a script. I've noticed lately, Crystal, that you haven't been sleeping. That's probably because you feel guilty for leaving children's. You knew I was going to call you out on that, right? And then, like, a lot of times when people aren't able to articulate this, pointing out what those behaviors are that you see that makes you come to that conclusion. You say you're fine, but you stop playing soccer. You don't come to dinner anymore. You're listening and posting a lot of sad messages on that Instagram account that you think your parents don't know about, but we do know about it, right? And then asking directly, are you thinking about suicide? Do you have a plan? How would you do it? And then that's your method, right? When was the last time you thought about suicide? So how impactful is this suicidal thinking for you? And then if you hear yeses, here's what you can do. Call their healthcare professional, put them on the phone with them, right? We talked about that already. And then safety proofing the home, just like when we had toddlers and we had to safety proof the home, you're gonna safety proof it for a teenager with suicidal thoughts. Calling the National Suicide Prevention Hotline, put them on the phone with them. Step out of the room, let them have some private conversation. Come back in and check in with them. And then I like the words being non-judgmental, right? You're not alone, we're gonna figure this out together. You're the expert on your feelings. I'm just going to support you with that, right? I may not know exactly how you feel or understand it, but I don't need to. I'm still going to support you through that, right? And it is a medical emergency. You're important to me, right? Kind of that solidarity. And then if you scroll down, while you're in that moment and you're trying to navigate how they're feeling and how bad it is, do you need emergency assistance right away? Do you have time to call prevention hotline? So kind of figuring out how emergent is this, and then how to de-escalate any crisis, right? Is calm voice, listening, don't stare at them. That makes people, especially paranoid people, feel uncomfortable. Kind of announcing what you're doing and moving slowly while you do it. Being patient. So then don't argue or try to reason with the person, right? We don't lecture people in crisis, we support people in crisis. And then if we scroll down, this is information that if you have, you're gonna have to share that with a medical professional. And then scroll down. Some more. So how to prepare for the crisis, right? Sometimes you can't avoid crisis. We're gonna go into crisis even with the greatest plan. But avoid guilt, avoid blame, don't argue, kind of more of what's already up there. And then scroll down. And then here's the plan. So their crisis plan is a lot more extensive than ours, but you can create your own template based on this and other ones if you want to do the research on it. So you're going to have maybe a diagnosis or presenting concern, what their behaviors are that they come in with, any current diagnoses, the history of suicide attempts, because you'll see in the research that you're statistically at risk for another suicide attempt within 6 months to 2 years of your first attempt, right? So, and then the same holds true for aggressive or violent behavior. Statistically, those that are at risk of aggression have been aggression in the past. It's the same with suicide. So that window of concern lasts 6 months to 2 years. And that's why we say that inpatient hospitalization is a great Band-Aid, but the work is going to be done in your outpatient care. And then if you scroll down, it's got the same thing we talked about, right? Supports in the family, when to call for a mobile unit or an emergency service, right? And that it's really a collaboration between the patient and the family. And once it's developed, you share that. So sometimes if kids seem to only go in crisis at schools, we'll do a crisis prevention plan that covers the school environment. You know, what at school is triggering to you, what can you do, right? Because there's coping mechanisms you can do at home. I can take a shower at home and pet the cat, but I can't do that at school. I'm not gonna leave school to go pet, unless Erica lets me. So kind of fine to, like, we've had parents who come in and they say, every time my kid spends the weekend at dad's, they come home in crisis, and that whole night is a disaster, right? So really tailoring it to the time or the environment that they go into crisis, that the pattern has been established that they're in crisis, and what we do in that environment to help you get through. So we have copies of NAMI's guide here, and then that's the website. And then this is a really great video of how to create a crisis plan.
So Steph, I know you just want to go home and you don't want to be admitted. However, I'm really concerned that you swallowed a whole bottle of pills last night because you were feeling down. Do you think you're going to do that again?
No, I'm feeling a lot better now. It was a stupid thing to do. I'm not going to do it again.
I'm still really concerned about you, and I need to know that you're going to be safe when you leave here. I need you to fill out this safety plan to ensure that you have strategies in place to cope when you're feeling down.
I don't really feel like filling out a plan, and I don't need a plan.
Well, I think that you do need a plan. You obviously needed a plan last night when you swallowed that whole bottle of pills. And I want you to fill out this safety plan to ensure you have strategies in place in case you feel like this again. It's a condition of your discharge.
I really don't want to.
This is really concerning for me, Steph. Perhaps you need to be admitted.
Fine, I'll fill out the plan.
So Steph, I know you probably want to get out of here and go home and that you don't want to be admitted. It must have been a really scary experience for you. I want you to know though that anytime you're feeling unsafe or at risk of harming yourself, you're always welcome to come back to the emergency department. I'm wondering what you think might have been helpful for you if this happens again.
I don't know. I don't think it'll happen again. I was feeling really down, but I don't really want to die.
Okay. Must have been a really hard experience to go through. Yeah. I'm wondering if you think it would be helpful to have some kind of plan in place or some strategies if by chance you feel like this again.
Yeah.
What do you think might be helpful for you to think about or to do if you did feel like this again?
I don't know. I guess I could have called someone.
Oh, so that's a good idea. Who do you think you might have called?
Maybe my Aunt Jenny. She's great. She's really easy to talk to.
So it's good you have someone in your life that you can talk to. What do you think stopped you from calling her last night?
It was so late. I didn't want to call at like 3 in the morning. It would have woken her and my uncle and all of my cousins up, and they'd probably just be mad.
Oh, so you're worried about disturbing them. I imagine that your Aunt Jenny probably would have been okay with you calling her given the circumstances and how you were feeling. Do you think you'd be okay with maybe having a conversation with her about her being an emergency contact for you?
I don't know.
I'm wondering maybe if I could bring your dad in right now and we could maybe all talk about this together.
Yeah, okay.
That's okay?
Yeah.
Okay. Hi, Tom. Steph and I are just having a conversation about safety planning, and I'm wondering if you want to join us.
Sure.
Great. So Tom, Steph and I were just talking about who she might contact in the future if she was ever to feel this way again, and she mentioned her Aunt Jenny.
Yes, I think that sounds good. Steph and Jenny are pretty close.
I'm wondering, Steph, are there any other things you can think of that would help you in the moment if you're feeling this down again?
I don't know. I haven't been doing the stuff I usually do for fun, like reading or, I don't know, going outside or hanging out with my friends even.
She also likes going for walks late at night when she can't sleep or isn't feeling good, but I'm just not that comfortable with that.
So that's concerning for you.
Mm-hmm.
It helps a lot. The fresh air clears my head.
I'm wondering, Tom, is there anything that Steph could do to make you feel more comfortable with her going for a walk?
I guess. If she were to let me know before she left, and maybe text me partway through to let me know where she is and when she might be home, that would help.
Okay. Steph, is that an okay compromise for you?
Yeah, I guess.
Okay, so we've talked about a few strategies today, and sometimes people find it helpful to write them down. And I actually have a template for a safety plan, so we could write down what we talked about. The other option is you could use the notes section of your phone. Do either of those sound helpful for you?
Maybe using the notes section on my phone. I always have it with me.
Okay, great. So let's recap what we talked about today.
Who would feel comfortable facilitating that? So in our ER, they're done by bachelor's level psychology, pediatric mental health specialists that have come from the unit. So I will leave that to this room, but if you have the template and they're filling it out, you could always have that person do it and then run it by the attending or the doc there, right? I usually take a peek at it as the evaluator, but I also am comfortable doing the crisis plan as well. But we're doing it with bachelor's level training. Any other questions about crisis planning or that interview or how that looks?
And I think for kids that you've seen before or that are engaged in services and they have a crisis plan, getting that and saying, okay, what about this didn't work, right? So when kids come back, we'll just print it out and go, all right, let's just start with
what we already have. Yeah. What did you try? And what did you try? Now sometimes I'll be honest with you and tell you I didn't try any of it. Okay, well that led to you coming back here. So, and then it does feel a little repetitive, but that's where they're at.
So I take care of a lot of kids that kind of refuse outpatient treatment, so I guess I should be doing these in my office, is that correct?
I'm surprised that more outpatient therapists don't use them, and that's part of what we're gonna start looking into is it that the kids aren't sharing it or the patients aren't sharing it with their therapist, because I feel like this would really guide your therapy with them, or is it that the therapists are doing their own and the kids are coming in and feeling like they're making multiple crisis plans but nobody's talking to the other? So I think if you have a suicidal patient, you absolutely need to have a crisis plan in place, right? Aside from your kind of chronic, even your chronic kids, right? Don't you want to know if they spike, what you should do for the spike and what you need to do when they come back down? So we encourage our patients to share these with providers. If it's for school, that they keep a copy of it at school, and that this is a living document, and every time you come back to the ED for assessment, we're going to pull this up again. Because we know that this is ultimately how you're going to get better, is learning to navigate your crisis. So here's an example of one we pulled for an adolescent, and this is how they filled it out. So we started with triggers, and maybe that person's trigger was pressure to do things above their ability, so high expectations, feeling unwanted, rejected by friends, social stressors, when others aren't concrete about what they expect from you. This was that person's warning signs: argumentative, biting their lip or fingers, doing the sighing, raising the voice. Other people with clenched fists, you'll notice redness maybe coming from the chest up, right? They furrow the eyebrows, so there's all kinds of warning signs. We have a coworker, when he starts rubbing his face like this, we know he's starting to get triggered. So when my parents or caregivers notice my early warning signs, they can talk to me, ask how I'm feeling, ask, quote, how can I help, give me a hug. Some teenagers, we've created code words for them. You know, like I had a teenage girl that when she says to her mom, leave, mom knows. You don't ask any questions, put her in the car and take her to the nearest ED because something either already happened or is about to happen. What they can do for themselves when they notice that they're starting to feel triggered, you know, guitar, music, deep breathing, journal. And then if they're unable to help themselves or accept help from those family or caregivers, then this is the crisis plan. Start with a call to the therapist, call the grandparents. If they can't get either one of those two, then county crisis line and then 911 if it's an emergency. Another way we've tweaked these is doing a number scale of interventions. So parent checks in with the kid, it says on a scale of 1 to 5, how are you doing? And the kid says 4. They've both determined before they left the emergency room what to do at level 1, 2, 3, 4, 5, right? So we sit down with both of them and we say, okay, at level 1, if mom says, how are you doing, scale of 1 to 5, and you say 1, that means you don't have any triggers, you're doing fine. Maybe a level 2 is, I'm starting to get anxious, I need a distraction, can you play a board game with me or cook something with me, right? And they've chosen what 1 through 5 means for them and how to intervene in each of those, and mom and kid both have a copy of that. So you don't have to type it into the notes section, you can use a template, take a picture of it, and it's on your phone, right? So that's an example for an adolescent. And then if you have a younger kid, right, it's gonna be a little different, a little more simplified. When kids call me names is a common trigger in this age group. Getting hurt, feeling scared, waiting a long time. Waiting is hard at every age. Early warning signs, maybe they're yelling, using posturing, not listening, right? So things that they can do, punch a pillow, take a deep breath, color, eat a snack. Maybe stimulants are wearing out, so this is a pattern, right? And then if they can't help themselves, they can call Aunt Kelly, therapist, crisis line, usually with a parent dialing and getting those people on the phone with them.
So I'm assuming with like nonverbal kids, parents are mostly
Parents are the ones that are
filling
doing
all
this.
this out.
Absolutely.
Okay.
Yeah, nonverbal, you're doing it with your parent. Absolutely.
But I also think it's super helpful, even if you have nonverbal kids in for a medical issue, to understand this and get that from the parent, if they're not at bedside or whatever, right? So that you are prepared, and so if you're taking care of these kids, to make that part of your routine for the day of, hey, I'm taking care of you today. What are the things that are gonna make it hard for you? And what do you want me to do when those hard things happen, right? And I know mom's coming at 4. How can I support you in that? And the same with the kids with autism, right? What are the things that might happen in the hospital, whether it's loud noises or unfamiliar people or whatever? And what can we have planned to set up to support them ahead of time?
So when you guys set this up and say a kiddo needs like visuals to go with these, are you guys the ones developing that, or are you just, this is how you can do it to the family, like telling the families this is kind of how you can
Depends on
develop
what their capability is.
Okay.
If they have the means and the ability, I think it's good to empower them to do so. I think if not, we've just drawn pictures on the whiteboard or on a paper and just have kind of a selection of pictures to go from.
We just Google image search.
Clip art.
Yeah.
Crayons.
Crayon.
Toys, things like that.
But for your nonverbal kids, if this is part of their medical record, then you have it and all the nurses have it, and they know when kid starts growling, he's gonna bite, or when you hear more of a humming or more flapping, this is what he usually does. Does he throw something? Does he hide in the corner? Does he defecate, right? And you would have that plan so that you can recognize warning symbols. So like when we teach acute care pool nurses and other nurses in the institution, we're like, so you use the FLAC scale for infants, right? You guys use the FLAC scale? Yeah? Okay. So this would be similar to a FLAC scale but for your nonverbal autistic kids, right? When you see this wailing or limbs are going this way, this is what happens with this kid. And if they do this, this is what happens. And this is what soothes them at each of those stages, right? Maybe it's a chew toy, maybe it's music, maybe it's a weight blanket or warmth or heat or whatever those things are, right? So they're individualized to the patient, to where they're at developmentally.
I just have a question on, where do you keep it in your electronic record? Is it on paper and then you scan it in?
No, we type it into its template.
So you guys actually type it in?
Yeah, yeah. Yep.
And it lands on kind of our home page where maybe other care plans or.
So everybody would see it,
Everybody would see it, it's red, and we know it's
go
red.
out
Still
and
a
they come
struggle
back
for
in.
people to click on that button and open it, but.
So there's something in your electronic record called like crisis plan.
Yeah, CPOC, BRAP, whatever, behavioral plan.
So it's like a note.
It's a note.
A note.
It's a template with drop down. So the
And the
versus my
template with
triggers
drop-downs.
are drop down.
Are you guys on Epic? Or
No,
We're moving to Epic.
We're moving to Epic, we're currently in Cerner.
Oh, okay, okay,
But, and it stays live in the patient chart for a year.
okay. And then how does the patient get a copy?
Print.
You
They
print it? Okay.
Okay, no, it's good, it's good.
I just have to
No,
get
no.
the formality of how this actually works.
Yeah.
Okay. we
And
can
it's
do
the
that.
same template in the ED as it is in the PPMU. It's the
No,
same,
we
it's the
can
same
easily
crisis
do that.
plan. It's not a mystery. And then when you're creating another one, or updating it, you just either open the old one and edit it, which I think you can only do an addendum at the bottom. Or you can open up a new template. You know, print the old one so you have it in hand, let them mark it up in the room, and then you type it into the new one, hit print. This one. Yeah. And in emergency rooms, you sharing this with their outpatient providers, you don't need an ROI, it's emergency coordination care. Even though a lot of people don't understand that when they have this conversation. Okay, so if you want to go beyond the plan or introduce the plan, that's when we do psychoeducation. So it's cognitive behavioral therapy based, so we teach them a little bit. This doesn't take more than 30 minutes, just so you know. We're not doing we're not doing therapy in ED. Psychoeducation is, hey, thoughts lead to feelings, feelings lead to behaviors. Now let's talk about how your thoughts and feelings have led to these behaviors, right? I think we should move to a model of including strengths in crisis prevention plans. I'm seeing that in the evidence-based research now. And really what you're doing is you're saying, so these are what's gotten you through in the past. How do we build more coping skills based on those strengths? If you are a highly musical person, what part of music can I activate for you in a time of crisis? I'm not musical or artistic. I can't use that repertoire of coping skills. But also like outlining that into your crisis plan or into like the trigger card. If you want to create your own trigger card, I would recommend that we put strengths in that. And then part of psychoeducation is also diagnostic education, and usually you do that with a parent. And we have, which we should probably use more often, some parent education flyers that were developed by Psych Consult, right? Developed those, or where did they come from? Psychiatrists over time.
Yeah.
So fact sheets on depression, disruptive behavior disorder, anxiety disorders, just fact sheets to let them know like this is what this disorder looks like and this is what you're going to see in your child, and just kind of giving that overview of what that diagnosis means for your kid. Lethal means counseling or for a safe environment we'll cover in the next section. So in conclusion, they're evidence-based, they work, the template can be done in under 30 minutes. You can start them, like print out the template and hand it to the kid and the family and let them powwow it out alone for about 15 minutes and come up with things on their own, and then go in and assimilate the pieces of information and kind of guide them through, like, this sounds repetitive, can you think of something else? Okay, how old is it's your 13-year-old best friend. Okay, that's okay for distraction, but okay, who's the adult, right? And then let them work on it, and then you go in there and coordinate all those pieces of information together. And then psychoeducation typically lasts under 30 minutes. So, and we'll show you what we use for our psychoeducation in our institution. Okay, so first let's talk about home safety standards. So this came from a study, and I don't have my notes in front of me. And I know the percentages don't add up to 100. That's not because I don't know math. It's because in the actual evidence-based study, they missed some data. So I think the ages were 13 to 35, and what they found was that from thought to action for suicide attempts, this is how the percentage of people, I think it was over 300 people, and how long it took them to do something, to try something. And the key takeaway here is that roughly 45 minutes, people will go from the thought to the attempt. And so that's why safety sweeping the home is so important. Because if you can create enough difficulty in finding an instrument or a method to kill yourself that'll last 45 minutes, you're going to save a lot of people. Because after 45 minutes, that crisis kind of drops off and they're not actively searching anymore. For 24% of the people, you've got 5 minutes, right? So if you can just make it so hard that you buy 5 minutes of time for someone else to intervene, or for that crisis, that height of emotion to level out, you can save them. So this is why crisis planning is so important. So going back to those methods like Erica was talking about, suffocation, firearms are huge, right? You gotta make it hard for them to have, if you're gonna keep those things in the home, right? Which our first recommendation is always to get the guns out of the home, right? And we're not saying you gotta sell them. Put them in storage, give them to a family member that doesn't live next door with an unlocked house, because that was another conversation I had. And I'm like, no, it's next door on the mantle. I'm like, the door, like, it's still not helpful. Separating ammo from the gun. The study that we had at Children's found that people that own guns don't own one gun, they own multiple guns. So really creating a lot of difficulty in work, like one code maybe is punched number code, the other one's a key, right? So creating a lot of difficulty in executing a plan. Can we click on this a little bigger? I found this online. This is a really neat, yeah, I think that's good, right? So your top three, right, are meds, firearms, and suffocation. So this website had like literally how to do it, like lock and limit. So maybe you don't buy the Costco bottle of ibuprofen or Tylenol, right? Instead you buy and you keep it maybe in the trunk of your car and you keep the keys with you at all times, or you buy a lockbox and you keep the key with you at all times, so that it's not available out and in the open, right? And that's in all bedrooms, because just because it's not in the kitchen doesn't mean they're not going to go to the parents' bedroom or bathroom and access those pills. Of course, always being around for watching, because you know that they're at risk, and listening. And then firearms, same thing. Lock them up, separate them. So this is a really cool little website to help us drive that message home. So once you've, any questions about ways to safety-proof a home? So lock boxes, trunk of the car, give it away, throw it away, storage, trusted friend or neighbor. So,
including like chemicals, a
bleach.
lot of bleach ingestions. Like you don't need the Costco size of bleach.
Or you can transfer it into a smaller bottle and lock the other stuff away, right?
And even vitamins.
Melatonin.
Quantities of it. I've seen iron. A whole bottle of iron is real toxic to them. So yeah.
Hard, isn't it? For I mean, think about it for gosh. You walk right out there and take it in. So
yeah.
It would be really hard to make your house
And you want to you want to tailor it to the kiddo, right? If this is a kiddo that their go-to is cutting,
right? Then you would
focus on that first, right? And know that it's temporary, right? This is to get you through crisis, right? Our kids weren't toddlers forever. We don't still live in toddler-proof houses with the funky doorknob thing, right? Unless what?
You're too lazy to take them off.
That's also true. Laziness will be covered next week. But it's temporary, and that's what you got to teach the families too, because it is very overwhelming, right? But we've kept some kids in the ED while parents went home to at least do a preliminary sweep of the home. We've sent CORES, our mobile crisis agency, and I don't know if we could activate CPID to do the same, to meet the parents at home and help them, because this is so foreign to them, and safety sweep the main areas of the home as well. But if you get the big three, you've done a lot, right? You get the firearms, the meds, and strangulation objects.
And
But
then
if they don't
also
strangle them, go ahead.
if they spend times at like their grandparents' house or anything, that they have to safety proof those areas as well, because there have been kids who are like, I grabbed my grandma's heart medication. So just knowing that if there was after school every day they spend 2-3 hours with grandma, that grandma also has to lock up her medications.
And if you're supervising and you know the area of the house that your kid's in, and you know what's there, right, then you kind of keep that awareness up while they're still in crisis. Any questions about that? So again, that conversation, the conversation about thoughts, feelings, and behaviors, and this crisis prevention plan that you fill out the template is all done as part of one psychoed piece. Here's crisis lines, in case you want to add those to the bottom of your crisis prevention plan template. You can pick and choose which ones you want in there. Somebody was asking about resources for gender and sexuality, the Trevor Lifelines, 24/7 nationwide line. Put that at the bottom of your template. Put Snohomish County Crisis Line at the bottom of your template, right? So they'll fill in their family members or friends, but you have included in it maybe the ones that you know they'll be most useful to your community.
And I think all teenagers need the text crisis line in their phones.
Yeah, because we text, we don't talk.
Yeah, they don't know how to call a person and have a conversation, right?
Speak out loud. Yeah.
And
Exactly.
speak out loud, right? Or we've had kids who they don't feel like their parents can know about what's going on, or they're having crises at school, and that's something that you can text and get help
In
right
the moment.
away.
And so when you text hello to that number, it just puts it on your scroll page. Apps, there's lots of apps. So last week in the ED, we helped a kid download Safe Plan, is another app that we like. That looks a lot like a crisis prevention plan. So this one is kind of like DBT-ish to me as well, because it's like things that'll distract me, things that comfort me, things that inspire me, pictures, people, like what's worth living for. So you can help them put an app on their phone or find an app on their phone if there's one that you like better than others. And that's to help with suicidal ideation. Some of the apps are more towards non-suicidal self-injurious behaviors, like instead of cutting, I'm going to try ABC. And then some apps connect, if your friend has the app too, then it's kind of like they connect through the app, so I can see your crisis plan and you can see mine and we can support each other, which I think is kind of cool. So these are a couple other examples. A friend asks, SAMHSA has one, the Virtual Hope one. More resources. So these are all prevention resource centers for all age groups, EBT, LGBTQ, how to ask. So if you have a friend or a loved one that's struggling with this and you just want to have a quick resource at your fingertips of how to say these things, because in the moment you're stumbling through your words, there's an app for that. Erica talked briefly about the partnership access line. So our psychiatrists provide consultation to any psych med provider in the state for consultation. And a lot of times when parents come in because they think their kid needs to be started on meds and we're not going to admit just for meds, we say go back to your PCP and have them call the partnership access line, and we'll send a copy of the CVAL to your PCP so that we're starting that conversation. And we'll have them make that appointment before they leave us. Like, PCP and schedule your appointment because we know you're discharging. And then this here is amazing for providers. This isn't something I would print out and give to families, but they've like created these manuals with diagnoses and how to treat them. Like even like, this is the first line of med to use and this is why. This is common presentations for disruptive behavior disorders. These are the therapy treatment modalities that work for it. And these are the meds that work for it. Like it's a provider guide, manual by diagnosis, and it's online. It's fabulous. So just if you want to educate yourself a little bit more around it as well, or if you want to give your psych providers extra tools, that's fabulous.
So the next couple hours is really going to be more focused on behavior management, escalation, understanding triggers and warning signs, and and interventions to manage those escalations when you have them. I wanted to just, I get a lot of questions from various providers all the time of, why is this happening? Why are we seeing such an increase? And I really go back to, I think just an increase in all kind of health conditions when kids are experiencing physical abuse, sexual abuse, emotional abuse, neglect, violence in the home, violence towards mom, substance abuse, household mental illness, that these are all risk factors that increase the risk of depression and anxiety, as well as increase the risk of suicidality, in addition to chronic health issues like diabetes or high blood pressure. Or so I really encourage people just to think about and sometimes, I push back on my ED physicians. They're like, why is that mental health eval taking so long? And I'll go to this list. This is why that eval takes so long. If somebody's talking to you about these things for the first time and how it's impacting their life, you're not going to cut that conversation short. And so thinking through the kids and the people that we see, how many of these risk factors do they have? And then thinking through that with that lens of, instead of what's wrong with you or why you're acting that way, of thinking what happened to you, what got you here, I think really helps people align. You know, some of the times I hear kids' stories, I'm like, oh my God, if I had that going on in my life, I'd be suicidal too, right? They hear those things like, yeah, suicide kind of seems like an answer in this situation. It's awful, right? And so being able to just have that moment of empathy, however unpleasant the behaviors are in front of you for that kid or patient, and being able to just think that through. So just more and more the evidence shows the impact of adverse childhood events being early alcohol and tobacco use, high risk of mental health, increased suicide, increased depression, sleep disturbances, high risk behaviors, and then poor maternal and fetal outcomes. So PAL will be expanding in the next year, I guess it's 2019, to provide early intervention for moms and try and get moms while they're still pregnant, hooked up with mental health services, showing that it can have an impact on babies' outcomes, of course, and kids developing mental health issues. If we can treat the moms early, can we improve the outcomes for those kids? So really thinking through what happened to you versus what's wrong with you. Remembering that the medical, any kind of medical care is potentially traumatizing to somebody, and so being able to just, if somebody's being resistant or they're acting out, being able to think that through. Has something happened previously, and is this medically necessary? Do I need to do this poke? Do I need to get this lab, or whatever it might be? Being able to provide basic support and information, address distress that they might be having. I always think of my dad. He can drive by Children's Hospital. I've worked there 18 years. He drives by and he turns green, right? He just has such a negative connotation with any kind of hospital setting that he is immediately triggered, not even having to pull into the parking lot, but just to pass by a hospital, he turns green. So families and kids are gonna be raised up a notch. Or, you know, I always think of, like, when I go down to Swedish, a lot of bad things have happened in our family in that hospital. So even if I'm going for a positive thing, I have that pit in my stomach. I'm already agitated, I'm already not at baseline, right? Just because of other things that have happened before. So, and giving, again, being able to look at the whole family and how is the whole family coping, right? Kids here for suicide, but is the family around them struggling to cope, and being able to give them resources. All right, we are going to, here, are you ready?
So, working in a hospital, my name's Hiro. I was a psych charge nurse on the inpatient psych unit at Children's, and now a psych consult case manager. So working in a hospital, we can no longer say in healthcare, I did not sign up for this, or I'm not a psych nurse. Oftentimes we have taken up holistic nursing, which means we take care of the physical and the mental health and the family health of our patients. We're going to be able to meet our families where they're at. Oftentimes if you're in the hospital, you're in some sort of a crisis, no matter how hard you seem to be holding it together, or a family seems to be holding it together, they are probably freaking out a little bit about something that's going on. And just being able to really provide them with that comfort to help them get through this situation. And we need to be able to assess and intervene skillfully, making sure that we are seeing when people are having a hard time and really providing them with that support firsthand, as opposed to, oh, this seems really uncomfortable, so I'm going to avoid it until I have to deal with it. Then it becomes a lot harder to deal with. So knowing that if we can assess people are having a hard time and really give them the things to help this go a lot smoother, it's really going to make everyone stay a lot better. And then to utilize the resources around us to support ourselves and the patients and families. So just knowing if we have social workers in-house, or if there's we need to raise a complaint to a higher level of our management, or if we need to call another facility to come out and do an evaluation for us, kind of knowing what all we have available to us to help get through this the easiest way possible. knowing how to do this is really important about knowing ourselves. So knowing if we are a fighter or a flighter, or if we are both, and it just changes in different situations. Another hidden third stage, does anyone know what the hidden third one is? Freeze, yeah. Which happens to everyone. Usually when you first come to a situation you've never dealt with before, oftentimes you don't know what to do, so you just stop and stare, and someone has to be like, hey, do something, and then you do something. Let's go ahead and, before we read all this stuff out, if you think you're a fighter, raise your hand. Cool, a few of us. If you think you're a flighter, raise your hand. Great, great. And then knowing that these can change, so I may be a fighter at work, but when I'm with like my mom, let's say I'm more of a flighter because I don't talk back to my mom. And so knowing that who you're interacting with, where you're interacting, can often change if you're fighting or flighting at that time. So the common behaviors for a fighter that we often see is you're ready to act. Others will come to you to take on their cause. Your response may elicit a defensive reaction from those around you. You address issues in the moment. You're able to easily share what you were thinking, and you often deliver your message with affect or tone. So the people who raised their hand as a fighter, does it sound pretty accurate to you guys? Okay, let's move on to flighters. Flighters want to think things over before acting. They may not view things as challenging until too late, which is an example of that is kind of just taking on more and more tasks throughout the day, and then you're about to leave in 15 minutes, you still have like 5 or 6 things you have to do, you said you're going to do. Bounce ideas off others first before deciding how you feel. Worry about the present/future due to past experiences. You may not deliver the message you think you are delivering. Does that sound pretty accurate to you guys? Does either of these seem better or worse for you to be? It's a trick question. Neither of them are better or worse. Because you need both. In certain situations, you may need to try and pull out your inner fighter and be like, oh, this is a situation that we really need to deal with now, and kind of stop this from escalating back further from escalating further. Or this might be a time of like, ooh, I really want to say something right now, but I need to take that like 2-3 seconds to stop myself from saying something, go take a break, and come back when I'm calmer so I don't make this situation worse. And knowing that both fighters and flighters have their natural advantages and disadvantages, and learning how to use parts of both being a fighter or a flighter is going to be super helpful when working with difficult conversations, whether that's with adolescents, children, or adults, or other staff members that you're working with. Are there any questions about this? This is going to be very interactive. The more questions you have, the better it'll be for you. Otherwise, it's going to be me reading a lot of this stuff. The way we perceive things often goes in the line. So the first is what we see and we hear around us. It's what we are experiencing objectively. So if I'm seeing people like with their heads down or on their cell phones or yawning, I'm like, oh man, what I'm seeing is people are not really interested in what I'm talking about. And then I tell myself a story, explain how you explain the experiences to yourself. You're like, man, I am really blowing this presentation because people are not paying attention, people are on their phones, people are looking real bored. And then it changes how I feel, how you feel about your explanations. I'm like, oh man, I am really not good at doing this. I just don't know why I keep coming to these. And then I act. And so what you do as a result of those feelings, I go tell my boss, Erica, be like, Erica, I really just need to not go to other places and present to people. Because I do such a terrible job. People are sad and bored, and it doesn't work out. So that's often how things happen, is we see something, we make a thought connection about what we believe is going on, it changes how we feel, and then it kind of changes what our actions are the next time. Isn't it supposed to go backwards too? No? Alright. And so what we need to know is how we can interrupt this, and knowing that each situation is different, and knowing that sometimes we go into a situation thinking, oh, I know that often this situation is really hard, is really difficult, and so we are already feeling kind of crabby about what we're going to do, or we're not in the best mood to tackle the situation, and knowing that assessing that we know that these are based off of our experiences, we could try and change our mind to be that we're going to start this well. Like, just because we're going to call this that usually denies our claims, maybe this time it'll go different, maybe it'll go better. And knowing that we need to try and put ourselves in a more positive light when we are trying to start interactions with things that we are already anxious about. This is a weird one. They changed the format of it. So we talk about carrying balloons, which is a sign for things that we can hold on to or things that we need to let go of. In the healthcare setting, there's a lot of things that we have to interact with, regardless if we want to or not. Some of these are a chaotic environment, verbal vomiting or venting, status of the patient, staffing/workload, what we hear about the patient or family, how we hand off, the family and their style of interacting. A huge difference in how our workday goes depends on which of these we choose to hold on to and really carry with us throughout our workday, and which of them we decide to let go of and not really pay attention to as much. So not all of these we can let go of. Some of these we have to stick with. So we're going to go through one at a time and kind of decide as a group which ones you think we can let go of and which ones you think we have to hold on to. So the first one is chaotic environment. You come in, super busy, lots of patients here. We have more patients who need to come up to our unit. Is this something that you hold on to, or is this something you can let go of?
Organize the chaos and let go.
Yeah, they not changed.
Yeah, use something you let go, because it's something that you can organize and make it better and do things better. But also, it's not just going to fix itself by us being mad at it. So it is something that we can kind of let go of the chaotic environment, do what we can to make it less chaotic, and fix it and make it run more smoothly. Verbal vomiting and venting. Verbal vomiting is just when you talk way too much, way too fast, you give way too much information. Slash venting. Is this something that we can hold on to or we can let go of?
Let go.
Let go of, yes. Because we want to make sure that how, this kind of goes along with the handing off, we are not being affected by other people's affects, and we are starting our day off the way we are feeling, hopefully in a good mood, hopefully we're doing what we like, making sure that if someone's really trying to process and dump on us their anxiety and their feelings, that we're not really letting it affect us and start us off as an anxious person on our shift. The status of the patient. Is that something we can let go of or hold on to? Hold on to. We can't really change the status of our patient. We are actively trying to change the status of our patient to a better status. But that is something that we're currently having to do. So depending on if the family or the patient has received pretty bad news, if they're coming in for a psych issue, if they just recently had a suicide attempt, or is just in a really bad place right now, that's something we have to hold on to, because that's how we're going to have to change how we're interacting with this person and this family in order to meet them where they're at, to provide them with an experience that will help them. We can't just treat them the same way we want to treat every other patient and just expect them to be able to follow directions. The next is staffing and workload. So like people calling in sick or not having enough people staff for your shift. Is this something we hold on to or you let go of? We have to say, no, we have to say this is something we have to let go of. Because again, this is not really anything that you can't change. People are definitely trying to change it before you get there. Oftentimes, if your shift's low, there's people in the shift before you who are trying to call in people or on calls, or if anyone wants to wants to come in and everything. But once you get there, there's nothing we can really do about it. So you want to let go. I think also people sometimes feel awkward about calling in sick. They don't want to call in sick, or getting mad at other people for calling in sick when they know it's a busy schedule. And knowing that if you can't promise that you'll never be sick, you can't get mad at anyone else for being sick. And it's just something you have to work through. So then, what we hear about the patient / family and how we hand off. Is this something we're going to hold on to or let go of? Well, kind of depends on how you do it. So how we hand off is a really important thing, and word choice is super important in the healthcare field. So if I was to hand off and I was to say like, hey, this family is super needy, they're going to be pushing the button all the time to try and get a hold of you, they're going to, anytime you leave the space that they can't see you, they're going to freak out and they're going to need your attention. That puts this family in a huge negative light, so then you're probably going to try and want to avoid this family. So you're like, I don't want to deal with that. However, if I phrase it as, hey, this family is very assertive, they really know what they want and what the healthcare needs of their child, they feel like they know what the needs are of their child. So if you are working with them, letting them know when you're going to check in and be very planful with them, setting expectations, then you'll likely have a lot better shift with them than I have with them. And so just framing things in a brighter light to help people kind of prepare themselves better and not just kind of get worried about the interaction they're about to have with the family. And last, family and their style of interacting. Do we let this go or do we hold on?
Hold on.
Trying to think of how I phrase this one. Yeah, hold on. We can't change how a family interacts. And some people, we often expect people, if they're coming to a hospital, are going to interact appropriately, and that's not always the case. That's not a problem. Some families, cussing is very natural to them, that they cuss at each other, kids cuss at parents cuss at the kids, and it's just very normal that they don't get in trouble. Some families are very loud, and they're just used to yelling at each other, and not even negatively, just like really loudly saying like, hey, how's it going? Just being very vocal. Other families are real quiet, and they don't argue a whole lot, and they're just very kind of calm and present. And you can't change any of that about any family. That's how they're hardwired, that's how they're going to be. And so knowing that if a family is used to cussing, they may cuss in front of us, and that's okay, because we're safe, and if it's just kind of uncomfortable for us, that's unfortunate, but if it's safe, then that's just how they're communicating. That's how they know how to communicate. Oftentimes too, if you're in the hospital, like I said, you're likely in some sort of a crisis, you usually go back into your kind of more natural acting in environments and the way you communicate and stuff like that. So them trying to be like, oh, I'm in a hospital, I need to act right, may go out the window if they're like, oh, but my kid's really sick and I'm really worried about my kid and I don't know what's going to happen. Did all of that make sense? That's kind of a lot of information. Kind of knowing what you can affect and what you cannot affect, letting go of what you cannot affect, and trying to adapt yourself to making it go better. We have some strategies. This is for in-the-moment coping. So when you are face-to-face with a situation, these are things that we suggest you can do. Huge thing is asking clarifying questions. Ask to see if what you think happened really happened. This is super important to get everyone's perspective in an event if an event is not going well. There have been often times where I was the charge nurse of the inpatient psych unit and I have to come and this kid is arguing with this coach and I ask them both for what's happened and sometimes I'll agree with the kid and be like, yeah, that was kind of unfair. And I'll try and settle the situation that way. We don't want to just assume that we know what was going on before it happened. Or there are times where I assumed things, I was like, oh, this kid's always off track, so I'm just going to yell at this kid, get this kid in trouble. And then later on the coach will be like, actually that kid was taking a break, I told them to go take a break, and you were wrong. And I was like, I got to go apologize to this kid now. So making sure you're asking clarifying questions and always kind of knowing exactly what is actually happening in a situation. We're going to change our perception, think to ourselves, how would I feel if this was happening to me, knowing that sometimes we get used to seeing the things that we see in the hospital and that this event could just be any other day for us, but if this is the first time a family is experiencing this, either medical condition or psychiatric condition, or maybe they've just never been in a hospital before, so they're really overwhelmed, or they're from Alaska, so they're really overwhelmed by lots of people in big buildings, that this may be completely new for them, in that we need to change our perception and kind of meet them where they're at and help them out through it. Create some pat phrases. Wow, to allow you to pause before doing the behavior you do when you're triggered. So if you're kind of a person who you naturally, when you get like surprised with something, you go like, you cuss, you're like, wow, what the F? If you say wow right before that, that hopefully stops you from saying what the F in front of a family or a kid and possibly getting in trouble. These pat phrases are just kind of something that you set up in your mind. It's just a kind of repetitive behavior you do to kind of help yourself prepare for things. Oftentimes I would start my shifts just saying, let's do this to the rest of my colleagues, because in my mind, we have to do it anyways. There's no choice. I can't just be like, oh, I'm going home. So saying, let's do this is kind of like, all right, guys, whether we like it or not, whether it's going to be easy or not, we're going to do this today, and we're going to try our best. Wow is just what our boss often says to pause before she cusses out loud. Not this boss, different boss. You want to reach for the caring empathy stance. So this is an example. I feel bad that anyone feels they need to yell in order to get what they need. So this comes from oftentimes if a parent has been yelling at us, you can get offended and be like, you can't yell at me, I'm a nurse or a doctor or whatever. Like, I'm a healthcare professional. You shouldn't be yelling at me. That's really rude. If a person is yelling, the only times I really yell at people is when I feel misunderstood. People are not listening to me, or they're disagreeing with me, or they just don't understand what I'm saying. Those are the times that I yell. So oftentimes with families too, the times that they're yelling at us is because they feel like they are not being heard or they're being misunderstood. Oftentimes people don't yell just to yell at people. They may have just a louder voice in general, which you need to be aware of, but if someone's yelling at you or seems really angry at you, there's usually a reason for it. They're not just trying to be mean for no reason at all. So knowing that, my example earlier is if we get a bad handoff about a family, and we feel like a family is really annoying, we don't want to be around them, so we avoid them for most of our shift, then this family realizes like, man, the nurse doesn't come by that often, or the doctor doesn't come by that often, so I need to start being more assertive. So they start pushing the button more, or they start yelling at the nurse, they start talking louder, because in their mind, they're not going to get their needs and wants met unless they're being more aggressive, assertive. And so knowing that if someone is seeming like they're in a bad mood, it's usually not about us, it's about the situation around us. In that we could figure out why they're feeling the need to yell and try to address that feeling, and that will help the conversation go smoother post-yell. This is a tricky one. Watch the event like a movie in your mind, but you don't want to ruminate on things. So thinking about what happened and replaying it can often change your stance. So knowing if you don't want to like just replay if you made a mistake, like, oh man, that was really bad, and then just get stuck on that and ruin your day. But you want to replay things of, oh, something that I could have done differently in this situation is I could have asked for another person to check in earlier, or I could have called for support from one of my coworkers, or if it was a dangerous situation, I could have called security earlier when I had that first bad feeling. Instead, I waited until this person was yelling at me. Or if you see interactions like, man, I thought my coworker was going to get screamed at by this parent, and they actually handled it really well. I'm going to replay this and see what exactly it was that they did in order to calm this parent down. Like, they went in, they asked questions, they validated feelings, and so just kind of replaying things that you want to do better can also help you out, and just kind of seeing what changes, because we can, in every situation we can make various changes of how we say, what we do, and just trying to think of which way things would have gotten better and which things would have made things worse. And kind of mindfulness, use your mindfulness techniques to keep yourself present, knowing that if we're getting tired, maybe we need an ice cold glass of water to help us stay awake, making sure if we're doing long shifts, we're using the restroom, we're not getting cranky for those reasons, but just kind of being aware of ourselves so that we are in our best shape for when we're interacting with other people. Are there any questions on any of these? These are after the moment coping strategies. So after you deal with the situation, you then go home or to a bar or anywhere. And these are some strategies you can do to, after you've had an interaction, to kind of see what would be better next time. So pre-plan new coping to keep yourself present. So working on your trigger card, knowing what skills you have and how they help out for when you are in certain moods. Some people are just like, I like running. Running helps me calm down. That's all I'm going to do everywhere. But you can't just run everywhere. If I just start running through the hospital, it looks real crazy and real dangerous, and I can't use that coping skill always. I listen to music all the time, but it's also super rude for me to be listening to music while I'm in meetings with my boss or other people. So knowing what other strategies we have available, which things work for which interactions. So a lot of people say exercise helps them out. Exercise, actually, when I'm really upset, makes me more mad because I usually make more mistakes. And then I get more frustrated that I'm making mistakes while I'm exercising. So I know that that's not a coping skill that helps me when I'm mad, but it is something that helps me when I'm sad or I'm lonely. So knowing that, which coping skills can be used for which emotions. We want to work to achieve a healthy work-life balance. We need to define what this means for each of us at this time in our life. Journaling can help with this. There are some people that we know that as they come to work, they're super jazzed. They're like, I love coming to work. I get to see my friends. I get to help people. I make people's lives better. And they get all their energy coming to work, and they're having a super exciting time. coming to work. And other people, they used to be like that, but now they're like, I really like going home, reading my book, playing with my cat, checking my paycheck on Fridays. And that's how they get their energy. And just knowing where you are in your time of life and what things you need to do to keep yourself energetic. If you're noticing that like you're the kind of person that work isn't super really charging for you, then maybe it's time for a vacation. Let's say you have a couple PTO days saved up. And just being aware of that and making sure that you're working the balance for yourself. Be open to identifying when you are challenged. Pick new coping skills from your trigger card when what you are doing is not working. So knowing that if there's a certain behavior or certain event that keeps happening to you that's really hard for you, being aware that that's okay. Hard things happen to everyone. If you're not dealing with it well, if you're seeing it that it's really kind of holding you down and making you frustrated, find out a coping skill you can do to help you feel better about that and get through that stress. But then also, you can view these challenges as opportunities for growth. Knowing that you gotta remind yourself that change is not happening to you, it's just happening. Self-talk, mindfulness. There are a lot of times that we run into things, especially if we've been in our position for a long time, and you just kind of have this feeling like, no, I know what I do, I'm really good at my job. And then you run into a situation that you have no idea what to do. And you're like, you feel bad, so you try to avoid those situations. We often try to tell people like, no, you should really practice those situations. Ask other people who are good at those situations for help so they can teach you how to be better and kind of not be scared to admit when we are having a tough time doing a specific activity. This experience, you can experience it, vulnerability as a strength, and it helps when you ask your coworkers for help if you're not having the best time doing something. Learn to say I made a mistake, or I do not know the answer. Do not feel incredibly bad if you do not know the answer or do not know how to do a task. That's natural for everyone. And then build in time to process. Is that running, walking, listening to music, talking with a coworker, and remembering that you get to go home at the end of the day, and that this family's reality is a reality that they never go home from. So if it's a long-term diagnosis, regression or something like that, the family has to go home and then continue to deal with this with their child or with themselves or with their significant other, and that at the end of the day we go home and we're not dealing with this anymore, but they're going to be dealing with it for until they get better. Alright, any questions on that? I talk kind of quick, sometimes I don't make sense, so if I ever don't make sense, please let me know. I'll try and explain it a different way, or they'll translate it for me. Alright, trigger cards. Some of you guys may have grabbed some of these from the table. I don't think we had enough. We can always photocopy some more if you guys want and make multiple ones. Trigger card is our easiest tool that we use with our patients. Oftentimes, whenever they come into our ED for a mental health evaluation, we can make a trigger card for them. If they go to our psych unit, we make a trigger card for them. If they are evaluated by our psych consult team on the medical floor, we make a trigger card for them. Trigger cards are very self-explanatory. They're cards with a list of our triggers on it. So we have on one side, and this looks a little bit different than the cards we hand out, but on one side it says triggers, so these are things that make me feel mad, sad, or upset. We feel like it is important for healthcare providers to know what makes a kid mad, sad, upset, or scared. That way when we interact with them, we can purposefully try to not trigger them. They're like, oh, I really don't like loud noises. And you're like, oh, this door slams every time I come in. Let me start closing it softer. Or you like it better if I knock when I come into the room, things like that. Just kind of being aware of what causes a person to get more upset, because if you can avoid those, then you have better interactions. The other thing is, when we get triggered, some people don't like telling people that we're triggered, and we just hold it inside ourselves until we explode. And so having a list of things that make us upset is really easy. So if you don't like talking about things that make you upset, but you have a list written down, sometimes nurses can read that and be like, oh, these are 3 things that happen here in the hospital that may upset you. Just so we can be aware of without having to have a conversation about it. The other side is warning signs. So ways people can know that I'm mad, sad, or upset because. And this is a good way for us to kind of just let people know what our nonverbals are, or just our behavior. Sometimes people can know that I'm upset because I start being more quiet and I start being more introverted. If you see me and I come in, I don't say hi to you, or I don't tell you a joke or say something funny, and be like, oh, they must be in a bad mood. Or maybe my face turns red, or I start breathing differently. I start doing like dragon puff breathing. Just knowing the different warning signs for someone is really important, because things that aren't necessarily like huge triggers, but you can start noticing warning signs in people in general. If they have a headache that's been going on for a while but it hasn't gone away, let's say if they're in the inpatient, they keep getting pulled into meetings, like doctors come in, talk to them for a half hour, doctors leave, we go in, we do vitals on them, we leave, a consult team comes, talks to them for 35 minutes, so like they just keep having meeting after meeting, so maybe they're getting triggered by not anything specific that is a trigger for them, but they're just getting tired and exhausted, which is causing them to be more triggered. And just noticing their warning signs from that can help us to kind of alert people like, hey, this person's seeming kind of exhausted, kind of triggered a little bit, like the next group of people that come in, like, hey, let's give them 15-20 minutes of break. They've been in a lot of meetings today. Let's let them kind of reset themselves. The back of your car.
I have a question about that. What is the conversation you have? So you do this with the patient.
Yep.
What is the conversation you have with them? Because I'm sure this is foreign to them.
Yeah.
And so they're like, what? What do you want? And so how do you have that conversation so you create something that's useful?
There are various ways to have that conversation. I'm pretty frank. I'll often just tell kids like, hey, I just like to know what makes you mad or sad, so that I can help avoid doing that, so that when we're working together today, we can be in sync. We can be working to help you feel better.
We can introduce it as a tool. We have a tool that we use for every kid in this hospital to help us understand how to better work with them. If it's a mental health patient and not a medical patient, then this is a tool that we use to build your crisis prevention plan, and this is a tool we want that lays a foundation for cognitive behavioral therapy, and we want you to take it with you. I carry one in my badge. I'll show you mine, you show me yours, and we do carry them. Mine's pink, not green. But we do it as an exchange of a tool. And every nurse in our institution is trained to trigger cards, and we encourage them to have them. Security that works in ED mental health is trained to trigger cards, and we encourage them to use it so that we have a common language within the hospital. But it's a tool. Help you understand yourself better and help you understand how to help you better.
And I've pulled mine out before, like the kids screaming, and they're like, oh, you know what, you're triggered by this, and screaming is one of my triggers. So I think I'm going to step out and work on calming down. How can I help you calm down right now? So then we can both come back. So just to be able to model to kids of like, oh, I bet this is really hard for you. This is the things that are hard for me, and this is how I manage it. And, you know, so that you're just modeling. Yeah.
And if they're resisting doing it, that's when I pull out my card. And so what I'm teaching you is not something that I don't use myself. Here's mine. And I let them read it. Do you have any questions about mine? Yeah, this is what helps me. Look, I've scratched stuff out because I don't just do this once and put it in my pocket and never see it again. On the inpatient psychiatric unit, we're supposed to review this as part of our debrief of every shift. Pull out your card. Look at yourself, look in the mirror for a few minutes and see if there's something else that needs to be added to this or maybe
I'll butt in one more second, and that especially when you've gotten to the point of like restraints with a kid, definitely it is a good time to reflect and go back and was it the kid's behavior that got you to that point, or was it everybody else's level of being triggered and exhausted by the child? So again, some behaviors require restraint, and some behaviors are just so unpleasant and annoying and constant that we respond out of, it's our reaction to cope is to make it stop. And so I think that's also another good place to bring it up and really think through, okay, if we're going to prevent this from happening next time, what do we need as staff, and what does this kid need in order to be successful?
And it's also really important to go over these after you've had an event with a person, because then you can kind of talk about like warning signs. Oftentimes people don't know all of their warning signs. When I was a little kid, I would like do this weird thing on my mouth. I'd like bite on my lips, and my brother and sister would make fun of me for it all the time. But I would not acknowledge that I would do that. I'd be like, I don't do that. It doesn't happen. You guys are liars. And so people sometimes have warning signs that they just don't notice themselves. And so kind of going over like, hey man, last time I noticed that like you got up, you were pacing back and forth a lot right before we had this incident where you got really upset and you yelled at the doctor. Is that a warning sign? You do that a lot when you're starting to get upset, and maybe they just didn't notice that, and that's something you can add to their warning signs. So the next time that they're having a hard time, they're starting pacing back, we're like, hey, I noticed that you're walking back and forth again. Is this a good time to take a PRN to help you calm down, or is it a good time for us to change the conversation or give you a break, things like that. We tried to fit it all into one slide in this one. So but on the back side of your trigger card is a coping skills section. On the left side it says my coping skills now. And then on the right side it says my new coping skills. Coping skills can be a lot of things. Most of them we want to try to promote is positive coping skills, but people do have maladaptive coping skills. So knowing that your coping skills can be like, I like to dance when I'm upset, or listen to music, go skateboarding, watch funny videos on YouTube, eat a snack, drink some water, drink some herbal tea, 5 senses. But people can also have maladaptive coping skills that are like, when I'm really sad, I cut. And we don't want to not put that on there because we need to know that that is a skill that people use, and we don't want to just take away skills, we want to replace them with more positive skills. Or knowing that some people are like, I smoke cigarettes when I'm really stressed out, or I drink when I'm really stressed out. Knowing that those are coping skills as well. Everything we do, every behavior we do, does have a form or a function that it does for us, and just knowing that is really important. So we know if we're like, oh man, I've been quitting smoking for a while now, so I'm just kind of on edge more, and it's not just, so I need to start replacing that smoking behavior with something else I can do to replace it, so I'm not just holding on to that stress without dealing with it. All right. Move on to environmental awareness. Does anyone have any questions about personal awareness? So knowing that the better we know ourselves, we can know when we are triggered. We know that if we are triggered, that we may be reacting less pleasantly with those we're interacting with as well. And being able to identify when other people are triggered helps us to change our approach to them. And knowing what they are triggered by also helps us to change our approach to them. So next we're going to do environmental awareness. So setting up our environment for success. Preparation is key. We want to prepare ourselves, we want to prepare the space, we want to prepare the patient, and we want to prepare the team. So preparing ourselves, physical preparation, knowing that if we are hurt or injured, if we're on light duty, knowing that is our badge here, is our ID readily visible, so people know who we are, that we work here, that we're working with them. Are we wearing jewelry that means a lot to us, that we would be really upset if a kid was to grab and break or pull? Are we wearing dangly earrings with a patient with a developmental disorder, where that shiny dangly things are really means grab me to some people, or little kids? Do we identify potential safety risk items that may be used against us or maybe distracting, as in our long hair, maybe we need to put it up so it's not easy to grab, our glasses, sorry, our watches, keys, rings, pens, clipboards, stethoscopes, etc. Just kind of being aware of everything in our environment, how it can be used, if it was to be used inappropriately, if it could be dangerous, do we need this stuff in our environment at this time? It can be kind of overwhelming at times, but as you kind of get used to knowing like, oh, last week the kid grabbed the stethoscope and started using it as nunchucks to try and keep people away from them. I'm not going to check this kid's heart rate at all anytime, so I'm going to take my stethoscope off and just not be in the room, take it into the room with this kid. And now that you have to be like super overprotective, just being aware of things that could be dangerous in a situation, so that you know to leave if people grab it. Preparing the space, simplify the space, identify building hazards, clear out broken equipment, identify exits. You have a way of contacting your teammates if you need support. So I often like to know if I'm trying to leave a space, like right now, if you guys got real mad at me right now, I'm in a real bad position, there's no doors behind me, I can't really leave, I'd have to go that way or hope that stairwell goes somewhere. So if I'm working with a patient that I know gets angry or gets upset, or sometimes it's physical or property destruction, I may often try to position myself closer to the door. Even if I walk into the room and let's say their bed's in the middle of the room and the computer that I'm going to use is on the other side of the bed, I may go and grab the computer and move it to the side of the bed that the door is on. So that if they get upset, I can be like, oh cool, I'm going to give you space, I'm going to leave. The other thing is I don't want to ever stand in front of the door and just be like, I'm going to stand in the doorway. That way I can always just take one step out and out of the room I can leave. Because then sometimes people feel threatened. They feel like you're trapping them in the room. So many complicated things about protecting your environment. But just kind of being aware of making sure everyone has easy access to a door in case anyone wants to leave. We can just let people walk out. Knowing, like I said, what equipment needs to be in a room, which equipment does not need to be in a room. Sometimes rooms have like lots of extra chairs for some reason. You know, we may not need all of these. Let's just stack them to the side of the room, put them out of the way. Do you have a way of contacting your teammates if you need support? I don't know how you guys contact each other else. We have, on the units, we have walkie-talkies, we have phones so we can call people. Oftentimes if I'm going into a room with an upset person, whether it's a patient or a parent or anything, I often let people know like, hey, I'm going into Kyle's room to do vitals real quick. You just be aware that I'm in there. And then when I come out, you just check me. I'm like, all right, cool, we're good. How do you guys communicate with each other? SpectraLink phones, emergency buttons, staff assist buttons, pull cords, cups and string, text message. Non-hypothetical questions.
We have whistles.
You have whistles? You really have whistles? Everyone has whistles?
In the rooms.
In the rooms? So you pull the whistle from the wall, you blow the whistle.
Never had to use them, but yes.
Yeah. And then what's your guys' general response to if you hear a whistle?
Should probably go check on someone.
Just go check on someone. So that's good. Be like, did everyone know that there was whistles and that's what the whistles were for?
That must not be on every unit.
It's not on every unit?
What unit is that?
Oh,
the outpatient clinic.
That's outpatient.
Most units have SpectraLinks. Yeah, no, we don't have whistles. No, most units have SpectraLinks. Not all,
SpectraLinks,
but
okay.
most units do.
Cool. That's really funny because you might be walking past outpatient clinic and be like, man, there's a lot of people blowing whistles right now. Is it like National Whistle Day? Or there's some kind of exposure therapy? But now you guys know if you hear whistles by outpatient that you could probably go check on that room. And just knowing who to call for SpectraLinks, knowing if you guys have a stat line or if you have a straight to security line, and things like that, knowing the numbers. The other important thing is just kind of know what to do also if you do respond to a situation where someone's in trouble, knowing what you're going to do, like, hey, let's have everyone leave the room, let's clear the space, make things safer. Knowing where we are sitting or your patient family in relation to the door, I kind of went over that. You want to make sure everyone has access to the door. Identify isolated settings, stairways, closets, bathrooms, medication rooms. So kind of knowing that like where your more vulnerable places are to kind of help inform people if you're going to be in that area for a period of time.
Next slide.
Next slide. Am I taking too long on slides?
Little speed up.
All right. Preparing the patient. Set expectations for care and keep them. So letting people know like what you're going to do. Like, hey, I'm your nurse. Oftentimes introducing your name, your role is super important. A lot of kids really like to know who they're working with, what they're doing. Kind of giving people time cues is really important as well, or how busy they're going to be. We're going to communicate clearly with patients and with families. If we're working with adolescents, sometimes we're just talking mostly to the families. The kids feel left out or they don't know what's going to happen. Are there guidelines of care for patient populations in your area to set staff up for success? So if you guys have a specialized guideline of care for patients with autism or developmental delay, augmented communication, or things like that that people can read up on before they work with this patient to kind of help them set them up for success. Does the patient have a medication regimen that supports their success? Knowing that if they have behavioral PRNs, are we giving them at the appropriate times, or are we waiting until they're in crisis to try and give them a PRN? Are their meds being given at the right times? One time I had a patient, they were like, this 8-year-old every night is just going crazy. And we look at their meds and like, well, you're giving their methylphenidate, which is twice a day, usually at 8 and 2, at 8 and 8. So at 8 p.m. you're giving them their ADHD med, and so they're going to be up and crazy. So let's identify that and address that. Identify the needs of our patient. Is there a coping skill you can have ready for the patient if they begin to have a hard time? How are you going to involve the patient and family today? So it's kind of being aware of like how not all pediatric patients are the same depending on their age. Do these kids like teddy bears and blankets and snuggles, or as a teenager that wants you to be real with them and be like, hey man, you cool, you good, and just checking in with them, and kind of identifying like what's the best way for them to communicate with you. And then preparing the team. Be consistent and predictable across shifts, knowing that have a set types of interventions that you will use and that everyone is aware of and knows how to use appropriately. Put high-risk patients in visible areas so that more people can be aware of the situation at a time. Use the buddy system for care. Rotate staff to prevent burnout. Being consistent is super helpful for both the teams and for patients. If every nurse is setting different expectations for a patient, then they're just going to get frustrated and they're not going to know what they can or cannot do. And then they'll do something that another nurse let them do, and then they'll get mad, and they'll be like, but Crystal let me do this behavior. And then you'll be like, but I'm not Crystal. And then they'll get mad at you, they'll get mad at Crystal. So making sure that if you are doing special things for a kid, you're letting the other team that comes on after you know. So that they are allowing the kid to do the same thing, or just don't make special rules for anything. All right, situational awareness. When things start to go awry. There we go. So assessing risk and safety.
Doesn't rhyme with Harry.
Awry?
Harry is it too. That works well.
And Eric as
well. Okay, so there's a significant difference between unpleasant behavior and unsafe behavior. And identifying which is super important. So someone in our old emergency department, we got yelled at, and it was just brought up every single time we would go down there, that we let a kid color all over the walls with a crayon. And they're like, you guys just let this kid just color all over the walls, ruin our painting. We're like, but the kid wasn't hurting anyone, and though we were trying to verbally stop the kid from drawing on walls, we're not going to go hands-on and possibly cause PTSD for this kid in hospitals just because they're coloring on the walls with crayons. No one's getting hurt at this point. So knowing when a behavior is unpleasant, are we using the appropriate approaches, or when it's unsafe, are we using the appropriate approaches? And how to identify those. At some point, makes you feel safe. So assessing risk and safety. As professionals, we need to sensitize ourselves to the reality that our patients and families may become upset or angry. An upset or angry patient or parent is not necessarily an unsafe patient or parent. In all interactions, we're constantly assessing the situation for safety. So kind of knowing that some families, like I said earlier, just talk louder. Some people cuss more openly, and to them it's not an aggressive behavior, it's just the way they interact. Maybe a cultural thing. We had a really good situation. One of our old coworkers, David Corrado, was talking. He's patient family relations, and this dad just kept getting like slamming the table, was just getting real frustrated because his kid was really sick and they was having trouble with the nursing. So David at one point was like, "Hey, I just want to stop real quick. I noticed that you keep hitting the table. Am I safe right now? Like, are you really mad at me? Are you gonna hurt me or anything?" And the dad didn't notice that he was doing that. That's just his natural way of communicating. When he gets frustrated, he has a hard time holding his emotions in, so he lets it out physically through the table. But David wasn't in any harm. He's like, "Oh, I'm sorry, that's just, when I get mad, I slap my fist down," or something like that. So it was a good way of David assessing the situation to see he didn't feel safe, so he brought up the concern and asked if he was safe. The parent was able to express, "Yeah, I'm sorry about that. I will try to manage my behavior better." Another way is, oftentimes, if we cannot ask someone if they are being safe or not, we can also use it based off just what we are seeing around us or hearing around us. So this is our tool, the safety ladder. We say patient behavior is a recognizable way to determine escalation. One of the most critical steps in maintaining safety for ourselves, others, and the community is recognizing these behavior patterns. In the next slide, we will review each rung of this behavior ladder in more in depth. Description of what behavior looks like, and listing interventions you can take. Starting at the bottom, because it's the safest, and you never want to be at the top. So, the very bottom is calm. Behaviors look non-threatening, calm. Interactions are friendly. We're learning and cooperating with each other. Our intervention to this part is rapport building. I often say the best thing you can do is learn how to become best friends with someone in 2 to 3 minutes. So knowing if it is young child, knowing like if they have any kind of like cartoon character on their shirt or trucks, race cars or motorcycles, pretending to be interested in that is super important, or at least being aware of that's what they like so you can bring it up later when they are upset as a distraction. Oftentimes too, people feel like they make friendships a lot quicker if they feel like they're teaching you something, so asking a kid to teach you something about that, like, oh, that's Doc McStuffins. Who's that other person that's with Doc McStuffins? Can you tell me about that? And they love explaining things. Even with adults, some people wear logos of their favorite football, basketball teams, things like that, or you just hear a conversation they're having with other people and just kind of knowing what their interests are, so you have a kind of in your pocket things you can distract them with if they start to get upset or talk to. Structure and routine are super important, so for some kids, giving them a schedule. Sometimes it's also really important. Some people will give a kid a schedule of like 73 things you're going to do throughout the day, and that's really overwhelming. So just being like, hey, first we're going to do this, then we're going to do that, then we're going to do that. And just having it 3 things, and that way when you're done with the first one, you can add a 3rd thing and just keep working your way down. And just knowing that structure and routine is really helpful. Sometimes giving kids time limits. It's hard if a kid's playing with an iPad or a Nintendo or something to be like, okay, we need to stop and do your vitals right now. And then they freak out because they didn't get time. But if you let them like, hey, me back in like 5 minutes, then we're going to take a pause. I'm going to check your blood pressure real quick, and then you can continue playing afterwards. Giving people time to transition. Not just kids, adults too. We all have times that we have trouble transitioning. Hopefully we react to it better, but sometimes we don't. Next is verbally agitated. Behaviors, patient begins to express their anger with the situation or circumstance. Verbal expressions may not be directed at any person or object. It may appear oppositional. So this, a good example of this, anytime someone's like, man, this sucks. This is really dumb. I don't like this. This is boring. All of that is verbally telling people that I don't like what's going on around me right now. Our interventions at this time is to provide support, validate feelings, and coach to a skill. So oftentimes if we hear someone be like, this sucks, this is dumb, sometimes we feel real uncomfortable, so we just ignore it, and we're like, all right, I'm just going to pretend like I didn't hear that, or I don't want to involve in that interaction. But kind of taking the time to be like, hey man, if they're in pain or something like that, since they're in the hospital, being like, hey, this is really tough for you. Is there anything I can do to help you out? Is there anything, are you not liking, is your bed not comfortable, you need another blanket, or pillow, or do you want us to bring over a movie player for you while you're here? Trying to figure out how you can help support them and making it so that they're not feeling like, this is dumb, this is stupid. Giving them some kind of distraction or something is what you can do at this time when they're verbally agitated. If we do not address them saying this is dumb, this is stupid in the moment, and they continue to get triggered because people keep coming in and talking to them or bothering them, or they're in more and more pain throughout the day, they then become physically agitated. Physical expressions may not be directed at any person. Behaviors may be directed at objects, i.e. drawing on a table, kicking tables, ripping up paper, things like that. So they were saying this is dumb, this sucks, we didn't help them, they're more upset now, so now the way I like to express this is like, earlier they were able just to kind of like, they're feeling bad on the inside, so they're trying to get out this bad feeling, so they use words. So like, this is dumb, this is stupid. That didn't help them out enough, so now they're feeling bad and they're starting to kind of lose control of their body a little bit. So I'm going to start drawing on the table, or I'm going to throw my pillow on the floor, or rip up some papers, or kick a table, punch a wall, things like that are my ways of expressing and getting out these feelings of bad energy, that I'm not happy, I don't want to be here, I don't want to be doing this thing. Good interventions to do is remove objects that can be dangerous. You can call for support, call for what we call a code purple in our hospital, whatever your codes are called. What's your code for aggressive person?
Code gray.
Code gray. So call it code gray, or 911 if you're in a place that does not have a code gray response to you. This little symbol with this X sound shows that we're removing objects in the environment. Next is verbally threatening. So the behavior, the patient begins to direct his or her anger at specific person or object, may indicate that there will be consequences if their demands are not met. This is where you come in again, you're like, hey, I know I was just in here, but I forgot to check your temperature last time I was in here, so let me come in and just check your temperature real quick. And they're like, no, you're not checking my temperature. Like, no, it's going to be no problem. You're not going to even notice this, and you're super easy. If you come over here and try and check my temperature, I'm going to break that temperature thermometer thing. And then you're like, no, it's okay. We're just going to be real quick. Don't worry. You're not even going to notice it. And they're just going to start, they're like, I swear, if you come over here, I'm going to punch you in the face. Just leave me alone. That's when they're becoming verbally threatening. At this point, it is really important to use short, concrete words, like, I'm sorry, I'm gonna leave, hope you feel better. You wanna give them space. You wanna call for support, call your code gray or 911. Oftentimes, if someone says they're gonna punch you, and you're like, oh, that's really not appropriate. You really can't do that because we're in a hospital right now. And you try to give them a real long explanation, they're not gonna listen to you because they can't, because their body physically, they have a lot of adrenaline, they're really upset, they don't wanna listen to us. It's not gonna go better, and that's gonna make them more frustrated. They will then be closer to wanting to actually punch you. So let's say they are physically threatening us, we're just continuing to push, like, no, we're just gonna come get this temperature. You start walking over to take their temperature. So they have to adjust their behavior again. So now they become physically threatening. Verbal demands are now stopped, and the person is using objects to threaten, i.e. chairs being thrown at you, even when you move to a new spot. So like maybe now they put up their fists, they start walking towards you, they try to look scarier, they pick up a chair or something. That is physically threatening, when they're trying to look very scary to you, so you stop doing your intervention. You want to stop coaching altogether at this point. You want to leave the space, clear the environment, call your code gray or 911. There's nothing you can really do at this point to calm a person down. You just want to make sure the situation is safe by keeping everyone away from this person and providing them with things that they need when they're able to ask for it. Or asking for things in a really calm way, like, hey, we're going to go ahead and give you space. If you need us, just let us know, we'll be out here. If we were to continue, like we're like, they're putting up their fists like they're going to punch us, but they probably won't punch us, so let's keep going forward and continue to try and stick this thermometer in their mouth, then the person's likely to respond by punching us. The person is not responding to any intervention, is now getting physical with people. Safety is our first priority. Restraint and seclusion may be needed, so if your staff are trained in going hands-on, this would be a time that we would probably go hands-on to stop a person from physically assaulting another person. If not, you should be just trying to leave the environment as much as possible, get to a safe place, call for your code grays, which hopefully at this point you should call for a code gray way before you get to a point where someone's punching you. But sometimes people are unaware. Or also sometimes you're working with people that, oftentimes with little kids, you can go from calm all the way to verbally or physically threatening instantaneously, just because they haven't built that kind of fuse limit yet. And knowing that some of our patients, if they are developmentally delayed, may not be verbal. So this verbally agitated may look different for these people, or they may not be able to verbally threaten you. So you may be able to take those steps. Also being aware of the paradoxical effect of a kid that is super energetic and hyper and like likes to tell jokes, likes to interact with you, likes to be all over your face. Verbally agitated or physically agitated could be them not doing anything. Them just kind of looking there really deflated, not talking to you, not interacting with you. It is possible to overreact when you're seeing these things. As soon as a kid like rips up a piece of paper, people can just like freak out, like, oh my gosh, this kid's crazy. Like, what's gonna happen? They can tear up anything. Call code gray. And sometimes people underreact to, they're trying to do vitals on someone and a kid's scratching them or biting them and stuff, and they're like, oh no, once we just get these vitals that are gonna be really high because this kid's attacking me anyways, and then we'll be done, it'll be good, it'll just be real quick. And then we underreact, and it's not until this kid continues to hurt more people that they're like, we should probably raise this to like our management or security or something. And oftentimes, after the first sign of violence, we should really be letting people know so that we can be making plans for this. That was a lot of information. I think my best way to describe this is, so you start off calm, you're asked to do something you didn't want to do. So a teacher asked me like, hey Hero, I want you to read this chapter in front of the whole class, and I'm really bad at reading, I mess up my words a whole lot, so I get real embarrassed, so I don't want to do that. Started being like, no, that's dumb, books are lame, boo. And then she's like, no, you're really gonna come up and read, everyone has to take turns reading, so I go up and I grab the book and I rip the book in half. And I throw it in the air to try and be like, okay, now, there's no book to read, I don't have to do this. And then she's like, boom, I have like 37 copies of this book. So she gives me another one, and I go, if you give me another copy of this book, I'm just gonna blow the whole school up. And then she's like, you don't have any bombs on you, I can see. We also have bomb protection and everything. And then I start physically threatening. I grab like the yardstick or something. I start swinging it wildly. And they're like, no, here's your book. They start coming out and hand the book. And then I start hitting people with the rule. Every step is like, I'm trying My best, which may not be good, those maladaptive coping styles. So here, I'm trying to say, I would really not like to do this. Please don't let me do this. But this is dumb. This is boring. I hate this. And it's just negative ways of when I say that and it doesn't work, moving to the next reaction to try and get people to stop asking me to do things I don't want to do. Does that make sense to everyone? That's a real weird explanation. That's how I always explain it. This is another quick sheet, kind of puts all the steps together, knowing that at the bottom, rapport building, structure, routine. You want to coach and validate feelings. As soon as people start to show agitation, as soon as someone says, this is dumb or this is stupid, that's your first opportunity to make a change in their behavior. Because if we ignore that, then we're not really supporting them. Then they become physically agitated, so that's when they start kind of losing control of their body. I think another big thing is oftentimes people are like, oh my gosh, this person's breaking stuff, or this person's hurting people. Let's give them medication to help them calm down. Up here, I often think this kid's starting to get upset and they broke something yesterday or they hit someone yesterday, so let's give them medication while they're down here so that it helps get into their body before they get really out of control.
I just wanted to jump in and say, also keep your eye on the ball around what the kid is in the hospital for, because we get into power struggles and escalate situations where maybe we just need somebody to take their antibiotic for a certain amount of days, and then we get in a power struggle about diaper changes or how this kid, like, that's not the reason why they're in the hospital. And so being able to keep your priority on getting those tasks done that you need them to be able to leave the hospital, and maybe putting up with, like, we had this sweet little 6-year-old, we think, but he had a mouth of a sailor, right? And so when he was anxious, when he was upset, would drop F-bombs and call people names, right? But he needed pretty complex medical care to be done. And so we were in this power struggle of trying to get nurses just to ignore the swearing. Like, he's anxious, he's pissed off, he's getting all of you riled up over these F words, and we actually just need him to accomplish this IV antibiotic and this procedure, right? And it was really hard for people to just, like, blood being permissive, and it's like, no, we're keeping our eye on the ball. He's doing the medical procedures that we need him to do. We can change, his family can work on the swearing and everything later, but the acute issue are these tests. If we get through those, then we can kind of hopefully ignore some of the other unpleasant stuff.
You mentioned that you give meds.
Yes.
What's your first line of medications that you guys typically use?
Not a doctor. I don't make those recommendations, but we often do.
But as a nurse, what do you typically give?
It depends on the kid. So antihistamine of either hydroxyzine, also known as Vistaril, or Benadryl can sometimes just be enough of 25 or 50 milligrams if that really helps to calm a kid down to kind of make sure that they don't get into crisis. We would then move to Risperdal or Ativan, and then lastly Halidol, if they are starting to get really unsafe, per our ED agitated patient order set pathway.
So we have an order set already built in. If the patient starts getting like physically agitated, we call a huddle with the attending and the resident and say, can you activate your agitation order set so we have these meds ready because we're going to keep climbing this ladder. So we always offer by mouth first. If they're hitting physically threatening and physically violent, we'll bring both meds into the room with a code team to say, like, you can take this by mouth or we have to inject you because it's emergency care. We don't have the environment that the inpatient site unit has of, closing off a wing so you can destroy it. We're in an ED. You have 4 exits to 45th Street. I ain't chasing you again.
And I think helping it frame for kid and family that it's an acute event. It doesn't mean that you're going to be on this medicine forever. It's really hard to be in the hospital. We're going to try and help you tolerate your stay and to help you stay safe until you get to a different spot.
So like we probably do antihistamine-ish around here to kind of help prevent them from going higher. But if they start to go higher, that's when you use the Halidol, Risperdal. And then also being really aware of checking how the reactions are to those medications, because like Ativan can often kind of have a paradoxical effect that just makes them care less about what they do, and they might be more assaultive or take their clothes off or things like that. So, and listen to parents too, because parents will also tell you if their kids had that medication. And so we did have this one patient at ISD who was like, you can give him Ativan if you want, but his clothes always come off when you give him Ativan. And so I'd use something else, and we're like, all right, so not Ativan. Our next thing is going to be the escalation cycle. This is graphing the behavioral event. This is kind of how we determine, we believe that all people, as they go into crisis, kind of go through the same pattern of behavior. Baseline is kind of the same as calm. This is when you want to build your rapport, you want to pre-plan with a person, set the expectations, let them know what's going on. Escalation is your safety ladder. So as you're starting to get upset, little things bother you and you work your way up. So like, let's say you woke up and you had a huge stomach ache and you were thrown up all day, so that you ended up in the hospital. That brings you, when you're at the hospital, you're not at baseline. You're upset, you've been thrown up, you feel crappy. But you're at the hospital, nothing seems to be working, you get admitted to inpatient, they say you're going to be there for a couple of days, so you have to call out from work and stuff. So all these things kind of keep building you up higher into your escalation. And if no one is helping providing you with coping skills, or you're not able to provide yourself with coping skills, then you just kind of keep going until you reach the crisis, the red zone or blue zone. Red zone is like angry crisis, blue zone, sad crisis. And so we say that as you get to about 3/4 of the way, that's when it becomes hard to kind of coach someone, and you really just want to start using few words and stuff like that. When you're in crisis, you really just want to focus on safety, and that's providing people with the space to be safe, or if you need to result in seclusion or restraint, at that point doing it. After they'll get through crisis, they are starting to wind down. Usually when you're in crisis, you have a ton of adrenaline going on, so that's why we often say, like, we can't just come in, make a person compliant. It usually takes 30 to 45 minutes for them to kind of even just get their body physiologically back to plan, which is in this de-escalation time. It's kind of just walking backwards down the ladder of, they're really upset, they're still pretty upset, but they're willing to listen a little bit, make deals with them, provide them with skills, a movie, a snack, something to help them calm down. Eventually get back to baseline. Then they go to what we call the gray zone, which is post-crisis recovery. After all their adrenaline's worn off, they are now more sad than usual. This is usually when like little kids cry after a big argument or fight, or teenagers like to try and isolate themselves and go to their room and be by themselves after a fight. This can also be when little kids want to like snuggle or cuddle for like reassurance that they're not hated or in trouble. At this time, oftentimes people will want to talk about consequences and what's going to happen to them. It's not a good time to do that because they are still very emotional at this point, and if you say the wrong thing, you're like, I'm going to take your cell phone away for 5 minutes. You'll be like, 5 minutes, that's like my whole life. Go all over. So at this point, you just want to continue working on behavior skills, give them snacks, let them rest, maybe take a shower, something like that, help them get back to baseline. You'll know they're at baseline when they're able to talk about something other than what just happened. We're going to go into some more detail.
So just to explain the various tools that we're presenting. The safety ladder, where we talk about the rungs of the ladder and all that, that's how we interact with a patient, right? We don't teach this to the kids and families, right? That's not part of crisis planning. The trigger card's for everyone, that's why we carry one as well, but also forms the template for your crisis prevention plan. The escalation cycle is part of our psychoeducation in the ED. So when somebody was asking, like, the kid's boarded so long that they've moved post-crisis, but how do you help the family feel safe enough to take the kid home? This diagram is very key, because what you can do with the family is graph out the entire event with them, and then show them where their kid is now and why hospitalization isn't needed anymore. And so we do this, we teach families the escalation cycle and how to help their kids feel better. And we also teach the patients that as part of their self-awareness, because all of us do this. Maybe our graph is shorter, maybe if you're manic, you're gonna spike a lot, but all of us go through this process of an up, a below baseline, and then back to baseline. That's our internal response. So if you can graph the event with the family and show them, but now your kid is here, unfortunately, because he's bored, but also fortunately, he's ready to learn again. That's why we know it's safe for him to go home. But if your kid is still here, no, you still need that safe environment. Does that make sense? So as we go through, yes, imagine that ladder goes right here, but that's your tool to intervene with them. This is for them to understand the event and understand themselves.
We're going to break it down into each zone individually. I'm pretty sure. No? We're not. So things to consider: assess developmental appropriate, albeit unpleasant, versus unsafe. So our patients are developmentally volatile. This is for our patients and their children, but knowing that people who are sick are not making the best decisions all the time. Children are egocentric and have difficult time seeing past or considering things beyond their own situation, especially if they have been in the hospital for an extended period of time. So they may be making decisions that they don't usually make, or they may not be thinking completely through it. We will encounter patients that have difficult behaviors or use poor language. It is okay for patients to be mad. Their behavior and language is not about us. So just knowing, assessing what is appropriate behavior, especially for little kids. I think sometimes people also get really scared about like fall risk and things is a huge thing. And then we go to a unit and they're like, this kid's been jumping on their bed for like 10 minutes. We're like, well, kids sometimes do that. Like maybe their parents at home play WWE or wrestle with them and do all that stuff. Like this may not be really scary for this kid, but we could try to explain to this kid that they can't do this in the hospital. But it's not, the danger is relative. Knowing the functions of behavior, we think that behavior has 3 general functions. It is either communicative, so the behavior can be used to communicate a message. That a person could be trying to obtain something, gain attention, avoid an undesirable task or event, express a strong emotion, protest about change or routine, etc. So communication can be for a nonverbal patient. Sometimes our kids are like, they'll just point to things, or they'll like pull you to a door that they know that usually when you go in there and you come back out, you have snacks. Or communicative can be non-suicidal self-injurious behavior can be communicative of, like if I'm cutting myself in front of someone, I'm not trying to kill myself, but I'm trying to express to you, like, I don't know how to put my sadness and my emotions into words right now, so I'm doing this in front of you and I'm communicating to you through cutting myself. I'm really sad and messed up right now, and I need some help. It could be self-regulatory. Behavior can be used to adjust one's arousal level. The person is responding to his or her own biological responses rather than communicating something. So this behavior could be, some people do work out and they get fidgety because that fidget kind of helps get their energy out. This can be crying. It can be, again, non-suicidal self-injurious behavior. These can be things that kind of help their body calm down. With patients with some developmental, they can be like rocking or the biting of themselves at times, going to help calm them down. The last is self-entertainment. Behavior can be used to occupy oneself during unstructured time or when bored. Sometimes this is just when you're just not paying attention to class, or you're causing troubles, or you're goofing off, or things like that because you're bored, and so you're just doing things to bother other people or entertain yourself. And sometimes it is really entertaining if you do dangerous behaviors because it elicits big responses from people around you. Do all of those make sense? Is there any questions on any of those? So the escalation cycle deconstructed. Understanding escalation and de-escalation. So first is baseline. Baseline is things that are moving along. This is say we're constantly trying to restore. Your presence often looks non-threatening. Interaction should be casual and friendly. This is where you're going to build rapport, kind of build that 2-3 minute friendship with this patient. Remember that our patients and families can be mildly to moderately escalated due to being in the hospital or having to come to our appointments. This means triggers will happen quicker, so especially if they're feeling like pain or nausea or things like that, they're going to be triggered more easily. Or parents are going to be triggered more easily because they're worried about their patient or their child. So our baseline interventions, proactive steps. So build schedules with kids, let people know what you're going to do, let them know who's going to talk to them, get foods and fluids available for them, provide structure and routine. Pre-planning things that will happen throughout the child's appointment or hospital stay. We'll set up staff and the child for success. At times too, when you can, giving a patient the opportunity to help build this schedule with you so they feel like they're helping planning it, really get the kids to buy in. Consider picture schedules. This says child life can help with that. You guys have a child life specialist in your hospital? No. So you can help yourself by making picture schedules, by either drawing, or pictures on Google. Find your most creative member and maybe do their vitals for them while they draw pictures for your schedule. I don't know. How you would like the family and child's active participation, so kind of let them know, like, hey, you might have to get a shot today. If you do get a shot, do you want to sit in mom and dad's lap? Do you want magic cream to make it so it's numb? Do you want us to count? Do you want to look? Do you want to not look? Letting them, having them interact with you, preparing for it beforehand as opposed to in the moment. Provide an environment that sets everyone up to do their best. Keep things simple. Distraction is always helpful during stress. Again, child life can help with that. But kind of being aware of you guys have cards or a stress ball or TV shows, movies, things like that that they can use to distract themselves with. What is necessary in the space and what can be removed. Learn about your patient and what they like and need when upset. And knowing that, possibly what you guys need to do is, if you guys don't have any like distraction materials like cards or things like that, maybe trying to figure out how you can try and see if there's a place that will donate cards to the hospital or puzzles or books or things like that to kind of help provide people who may not have those at home that they can't bring in. Baseline interventions by diagnosis. So for a patient in psychosis or bipolar or agitation, we want to do low stim activities. So having less people at a time, having the lights dimmed, be in a quiet environment, intervene with meds early, and to treat their symptoms. Just really kind of making things real calm. Also just reorientation is huge. Oftentimes if I'm working with a kid with psychosis or things like that, or even just agitation, I'll often be like, hey, it's me, Hiro, I'm your nurse. And I'll maybe say that 30, 40 times throughout the day, just kind of make sure they're aware, like, oh, that's my nurse, that's Hiro. What's up?
Have you ever seen those rooms where like it's just like a kind of like a seclusion room, but they're not locked in, but like they can change the lights and make the music and stuff? And
Comfort rooms.
Comfort rooms.
Or sensory. We have them on our inpatient unit.
do they work really well?
It gives you a safe place to calm and still maintain visual versus letting kids go back to their rooms, which then creates all kinds of logistics and vision issues. And it also models for them, you can practice these and create something like this.
Also, if used at the appropriate time, if like it's an early intervention as opposed to like, you don't want to send them in while they're already punching holes in walls. Be like, let's send you to this other room, punch holes in this wall. But if you start to notice they're starting to pace, be like, oh, you look kind of antsy. Like, come to this room. It has these tools in here, or it has low lights, like that. Interacting with depression and SI. You want to have the curtains open. You want to be encouraging interaction with them, distraction, monitor conversations with roommates, redirect suicide ideation, talk, work on crisis plan, kind of just the more you interact with them, the better. Ask them what they like, ask them about their interests, talk to them about those things. Working with patients with ADHD, interaction helps. Providing structured activities help. Structure helps with them. Stimulants can help. If you give activities, make sure you're controlling it. We have Legos on our unit, and sometimes a coach will just give the kid the whole thing of Legos, and then you have the whole thing of Legos everywhere. I'll often give a kid like a handful of Legos, but all right, when you're done with this, you can ask for more, and I'll give you more Legos. But knowing that if you're giving an ADHD person something, that like you're being really aware of what you're giving them, how much you're giving them, like that.
And do you guys have any problems in administering your pharmacy stocks stimulants to give the kids? I was at Providence in Yakima, and they have a problem with their pharmacy that doesn't stock stimulants for the kids, and so they're off their meds over there. Yeah, okay, good, we're good here.
No, they.
Methylphenidate, a hard time with?
Yeah, sometimes they have to get their meds from home, and then we
Okay, that's good. Because the other hospital, they won't even allow home meds to be given. I was like, I'm going to help you write a letter to your head pharmacist because this isn't safe to give for kids with ADHD, stimulants in the hospital. They can life a lot harder.
And then baseline interventions for patients with autism using pictures, triggers, and coping from family, structure, expectations. Oftentimes just really involving the family, asking the family too, like, hey, how do I know if they're having if they're feeling hurt, like if they have pain, or how do they communicate? What do they do if they need to go to the bathroom? Do they have a thing on their iPad that helps them communicate, or do they use text pictures or things like that? And just really working with the family because they know them best. Medications, so we have agitation order set, have PRNs ready, so we often offer PO, risperidone, Ativan, or Halidol first. And by first means before the shot version of this. Some adult data show PO risperidone works just as quickly as IM haloperidol. Easy PO forms exist. There's liquids, there's small pills, there's dissolving oral tablets that taste kind of minty, so I hear. PO administration favors child cooperation, treatment alliance, needles often increase agitation. Our IM is usually a last resort due to safety. It's also less trauma-inducing, and restraint reinforces the idea of violence, of using violence to resolve conflict. We often want to teach kids that they can make the right choice and giving them the option of like, hey man, if you just choose to take your medication right now, we can then let you chill for the next half hour. We won't bother you, we won't do anything. And then hopefully in that half hour they'll calm down with the medication. You can prove to them like, hey, cool, next time, let's try this again. Instead of us arguing for 20 minutes before we get to this, like let's try starting with the pill and taking a break and things like that. And teaching them that they can make better choices so they don't need to argue and do what they want.
Do you have data on your restraint rates, or like, do you have a percentage or number, or do you have any data on your restraint
I don't have
numbers?
the percentage at the moment.
Okay, how often are you restraining? Every week? Every day? Once a month?
I would say our ED and our psych unit probably average 20-ish restraints a month each. And it's often the same kids. So, I mean, that the kids that require restraint in the ED are often the ones that require restraint in the psych unit, just because of they're usually acutely psychotic and not up on their meds yet.
Okay. They must be in and out of restraints pretty quickly then.
Yeah, most of our restraints are less than 15 minutes.
Oh, less than 15 minutes?
Yes.
That's interesting data. That's very interesting data. Okay.
That if we go down that path,
okay,
we will hold a kid, potentially put them in restraints for a time, get the medication in them. Even if they're in restraints, we still give them the option of taking the medicine orally, if they can. And then give that med a little bit of time to work, and then start paring down restraints and trying to move towards some kind of comfort, whether it's a blanket or a movie. Again, we're not reinforcing behavior in the hospital, so whatever that kid needs to be safe after that restraint event, we are gonna do.
What's the longest you had somebody in restraints?
Depends on the order, on the age.
And the diagnosis.
Well, yeah, we never exceed.
For a teenager.
2 hours is your maximum for each order.
Yeah, I can't think of the last time we exceeded 2 hours.
I think the longest ones we have are
So
due
it's been
to,
years. That's interesting.
at least for agitation, because it's hard to stay that angry and hold that much adrenaline for that long.
Yeah.
The times that we have to have restraints for the longest is usually like patients with developmental delay that need an NG feed that keep pulling it out or something like that. And so for a medical intervention, your restraints are typically longer than for agitation interventions.
But we also have docs that can be aggressive-ish with meds for agitation, right, and be responsive, and
Getting those meds in
is huge. Yes.
Yeah, I'm feeling
The
that.
biggest reason.
I'm thinking it and now I'm feeling
And
it.
that's why we have that
Otherwise they're not
agitation
calming
order
down.
set already developed, so that you don't have your typical medically trained doc trying to pick a med. It's already in there. Try this first,
Sure,
that
we'd
doesn't
love
work,
to
try
see that
this,
order
that doesn't
set.
work, try this. And it's already embedded in their order.
And it took time to shift our ED and PEDS docs around to that philosophy of really trying to reinforce, like, this is safer, you have medical monitoring in place, we can do this, you have consultation available, like, and really seeing that they're able to move care along.
So it's your pediatricians who are ordering the meds, not the
Yep.
behavioral health team.
Correct.
Right.
Okay.
It's already
I just
been-
was wondering about
The
that.
behavioral health made the recommendations. They
Okay.
built an order set, and now any doc can order that order set.
And we actually already use this. We use this here.
So escalation, next step, this is when people start to get triggered and start to move up the ladder. Escalation happens after a person has been triggered. Sometimes you can see things and sometimes you can't. They can be internal triggers or external triggers. So internal triggers can be headaches. Sometimes when I get really hungry, I get really angry at the same time. It's a weird coincidence. Something that happens to other people too. They are different for everyone else. So some can be loud noises can bother a lot of people. Sometimes it can just be like different feelings. Textures. We want to listen to everyone and everything around us. When we are triggered, we show warning signs. These warning signs can be the first indication of a move into crisis. So this is where the problem starts. So this starts usually the next 3 steps of the ladder. So verbally agitated, physically agitated, verbally threatening. That's why it's really important that we look at people's triggers cards so we can kind of know what their warning signs are. And then as we build rapport in the first calm stage, we also kind of know what kids look like at baseline, so we can tell if their behavior is different. And then our interventions for early escalation, we use Gottman's emotion coaching. It's a 5-step process. The first was to be aware of the child's emotions or the family's motivation. Recognize emotional expression as an opportunity for intimacy and teaching. So when we seek to understand the child, that is when they feel they are being supported. Refrain from discounting or criticizing feelings. So that's the same as like when we tell kids like, there's no need to be scared of getting a shot, it doesn't hurt. You just stop their thing, and then 1, shots do hurt, so you lied to the kid. 2, they feel like they have to just like, oh, I'm not supposed to be scared, but I am scared, so I don't know what to do. And they just hold the feelings inside, so once they finally see the needle, then they explode. It really is not. So what you want to do instead is be like, hey, I hear that you're scared. I can see what's something that we can do to help you feel better. Do you want to hold my hand when we get through this? Have you ever had a shot before? Do you want to watch? Do you want them to show you the tools before? Do you want them to count? So you want to listen empathetically and validate the child's feelings or the unmet need of the family, making eye contact, validate, ask before giving advice. You want to label emotion in words a child can understand. So saying like, man, you sure look perplexed and frustrated, and then just be like, I don't know what you said, I'm gonna punch you. But instead of like, hey, you look really mad right now, and then they might even say like, I'm not mad, I'm really scared right now, and you're like, oh, that changes everything I was just about to do with you anyways. So trying to label things in words they can understand so they can tell you if that's true or not, and then you can interact with them appropriately. Also, just the act of labeling emotions in kids, or anyone actually in general, can often have a calming effect on themselves of just kind of reassurance, like, hey man, you look really sad right now. I was like, I am really sad. And even just kind of like that feeling of validating of other people noticing helps them to kind of soothe a little bit. Step 5, we don't do until we're back at baseline, but we want to help the child come up with an appropriate way to solve the problem or deal with an upsetting issue. So when I help children with step 5, when they're back at baseline, as this discussion can further escalate the child. So the huge important thing is we don't just create solutions for people, we help build solutions with them. They're more likely to buy in and do it if they feel like they created the solution themselves. It also helps teach them that they can create solutions for themselves. Are there any questions in this? A huge thing about this, and basically everything we're teaching you right now, is everything takes practice. You're not going to be able just to listen to this 4-hour presentation we're giving you today and be able to run through this. Like, you need to start with the smallest problems, and that might just be like, I notice that my coworker always gets cranky at hour 4 because they haven't eaten yet, so I need to start tackling this process. And 2 hours in, I sneak them a snack. Be like, yo, I brought cheese and crackers today, and things like that. And just start working on small things and work getting better at fixing small problems that aren't big, and then you can tackle bigger problems. Escalation interventions, so try to understand the need of the child or the family. What are they trying to communicate with their behavior? Is the behavior communicative? Is it self-regulatory? Is it self-entertainment? I always like to think of these as like puzzles. It's always trying to figure out, they're doing this behavior for some reason. If I can figure out why they're doing this behavior, I can usually get them to stop, or it doesn't bother me anymore that they're doing this behavior now that I understand why they're doing it. So these are usually your first 3 clues of trying to figure out, what are they trying to tell me? They're not trying to tell me anything like, oh, this behavior is because their back hurts a whole lot. So moving like in this weird way is really helping them feel more comfortable. So now I understand why they're doing this. Or if they're self-entertaining, being like, oh, they just keep doing this because they think it's funny that the nurse comes in every time they do this, so let's just switch the monitors or not come in or change our reaction. We want to coach kids to an activity that can work to calm them or turn them to baseline. So playing and building rapport can count. Call for support if the child is unresponsive to coaching. So knowing that like as you interact with a kid that is upset, sometimes just by distracting them and moving them on to the next thing is really helpful. These are our most common interactions or interventions for interactions we see. So for patients who show anxiety, and for all of them actually, we want to actively listen. But for anxiety, we often want to emotion coach, identify their emotions, understand what is making them anxious, provide them with the appropriate level of information to help alleviate their worries. An open dialogue, so either explaining a procedure, having a doctor come and explain the procedure they're going to have, let them know when people are going to see them or when something is going to happen. Super helpful. For anger and frustration, we want to actively listen, apologize for their experience, emotion coach, understand their situation, try to problem solve with them. The key thing is apologizing for their experience. We don't want to, we're not saying that like we're doing anything wrong to them, but we're saying like, hey, this is really frustrating. I'm really sorry this is happening to you. How can I help you out? How can I partner with you? If patients or family are demanding or persistent, we can actively listen, emotion coach, understand. We want to identify what we can do. It's really important that they know like these are our options of what I can do to help you right now. If necessary, we can identify other resources that may be of additional help, which may be my manager, or the doctor, or a security guard, someone that may have different privileges than I have to help this person out. Language barriers, we want to actively listen, try to understand. We don't want to rush the speaker, we don't want to shout. We can use a language line, if you guys have that here, or contact an interpreter, or use language reference tools if you guys have those. You guys know what splitting is? No. Splitting is when I ask Laura if we can go get ice cream afterwards, and Laura says, absolutely. Oh, you're supposed to say no. Sorry. If I ask Erica if we can go get ice cream after we do this presentation, she's like, no. I was like, Laura, do you want to go get ice cream after this? And she says yes, so I'm splitting them. It's like the mom versus dad argument there. And then we outnumber her and we're 2-to-1, so we go get ice cream afterwards.
Can I pay?
Right, she's buying us ice cream.
It's on video. So splitting, you want to actively listen to the patient or the family member. You want to emotion coach them. You want to identify what we can do for them. And know that it's okay to refer them back to the original person or say you need to validate the information. So oftentimes if you're like, oh, the other nurse totally said I could do this. And you're like, cool, let's go ask the other nurse. They're like, oh, we don't really have to bother her. Or like, the doctor said I'd be getting this and this and this. And you're like, all right, cool. Let me just call the doctor real quick and have him come by and we'll check in and he can write the orders. And it's super important to validate with whoever's in charge of a patient if what they're saying seems off or seems splitting. I do this all the time. If I'm not in charge of someone and they ask me for something, I'd be like, cool, I totally can't help you with that as soon as I find out who your nurse, doctor, coach, staff is. Last is insulting, blaming. Actively listen, emotion coach, ignore the insult, don't personalize the insult or blame because it's usually not about us. And we want to problem solve with them and apologize for their experience, kind of knowing that there are times people are going to get mad. It is easier to get mad and yell at a person that you have no relationship with, i.e. your nurse, doctor, social worker, security guard, whoever's in the situation, because they they need to get these feelings out, and it's often not about anything we did. It's about the situation that they're in. So just being aware of that. Sorry, one more thing with splitting is knowing that we can do this to ourselves. If I bend the rules and let a kid do something that normally they wouldn't be allowed to do, and then Laura's on the shift next, and then she doesn't want to bend the rules for that kid, then I caused a split between our policies. And I've caused a harder day for Laura, which can get really frustrating. So making sure that you are trying to do things for kids that everyone else would be willing to do or can't do for them. Crisis.
We have a question.
Question.
What's the shortest amount of time you suggest for a teen when they violate something on their contracts, like you take away the Wii or the TV or something? Because some people are like, oh no, that's it, it's gone forever, and some people want to do it for 2 days, and it's like, does it just vary on?
We often set expectations. It depends on in the moment if it's like a repeat behavior, or the expectation depends on what they did. So like,
did you set it up front then? Be like, so if any of these get violated, then it'll be like 2 hours of no TV or.
That's the way to ensure consistency, right?
Yeah.
So you set expectations. Remember when we were talking about preparing to do the work. So does the team agree? Is that the expectations we set as a group? And then have they been informed before the behavior that that's what the behavior will lead to?
Right.
So if you make that highly visible to everybody, then you eliminate the bad guy.
Yeah. And making sure it's something that you can all involve, but also knowing that like, if the Wii or whatever is something that helps them out in stress, that you didn't just shoot yourself in the foot by being like, all day, it's gone.
Yeah.
And then you're like, oh, this is only one intervention. So constantly setting that shorter time intervention, or setting the expectations of like, oftentimes if a kid does a problem behavior, being like, okay, well we need to fix this issue. Like you threw all your food tray all over the floor, so we need to clean this all up before we can move on to something.
That goes back to that unpleasant versus unsafe thing. Like if the we is the punishment, I really question what the behavior was, because you want there to be a natural consequence, right? So did they break the last we? That's a pretty high expensive resource versus they broke the last crayon, right? So I don't know if I'd give a kid a we back if they broke this. Like you broke it, now we're gonna have to.
No, we wouldn't have another one. So
Yeah.
I worked on this car. I don't get another car. Go figure.
Exactly.
And it's the natural consequence that follows it.
Yeah.
Well, partly the whole natural consequence, but then I'm assuming you guys also set up like, okay, these are the expected behaviors and this is what you get as reinforcement rather than ahead of time.
Exactly, and those things are changed by environment, right? In the emergency department, I'm like, if you leave this space, I have to go hands-on because we can't, because of the external exits, right?
Yeah.
On the inpatient psych unit where you have wings that can lock and contain, okay, you can have a longer leash with behaviors, but is your environment set up for that?
So the consistency helps. I think also the way you word it too is so, like, coming back to like, I don't often try to set limits with kids. I set expectations, because expectations just sounds more positive, or seem like willing to try and follow expectations as opposed to like, you can't do this, you can't do that, you can't do that. Some kids have to be like, oh, I can do that, I will do that. Or like, hey man, expectations, we're gonna try and work together. We're gonna try and get through this. We're gonna try and get all your medical stuff done so we can get you doing some fun things. And setting expectations is like a more positive way of framing things.
Well, expectations are universal, right? No kid leaves this emergency department by themselves. Not you, not the medical kid, not the pneumonia kid, right? That's an expectation of our department. The limit is I'm setting on you because this is getting out of hand and this is your individual limit.
That's where I think, just on our unit in particular, I don't know if it's true of everywhere, we have a hard time setting a lot of those limits, and because it really varies from kid to kid. Oh, sorry, I'll try to be quick. But like, when you guys talk about the behaviors you see and whether it's just unpleasant or not, sometimes that affects our entire unit. So is it just unpleasant, like I'm telling a 7-year-old, no, you cannot yell F-bombs in the hallway,
Right.
because we have other patients and you're disturbing other patients.
Right.
So if you want to go into your room and yell them, I'm fine with that, right? Because that's not hurting anybody. But like to have them out in the middle of the hallway screaming down when I have babies and families and other parents that are getting concerned about the safety of our unit is really hard to then.
And I'll reflect that back to, sorry, go ahead, I'll have that you know what, right now, this behavior is really upsetting to this little baby with pneumonia. We used to have the psych unit below the cancer care unit, and the kids would throw the balls at the windows of the cancer care unit. I'm like, do you realize that there are kids up there dying of cancer? Would you like to choose a different spot to throw the ball? Ooh, yeah, sorry, okay, right? Like, most kids don't want to harm other people typically. So just being able to, like, let me help you understand the people around you. This baby's really sick. This parent's really concerned about this.
But then on the same token, am I gonna go hands-on the F-bomber in the hallway? No, but will I go tell all the other families on the unit, I've got a kid that's having a hard time, I don't wanna go hands-on because I have trauma, like, without revealing everything, like, our philosophy of care is least to most restrictive. I'm sorry, this is really unpleasant to listen to. Can I put the TV up for you, spread some soft music or whatever it is while I'm working with this kid, right? So I had a kid in the ED who would kept coming out of the room without a shirt on, screaming like he had Ebola. He also was claiming rates of how much he would pay for prostitution with all the females, and I'm like, but I needed him, it was manic, I needed him manic because I was trying to get him detained, so if I calm that down too much, I couldn't convince him, and I'd been trying to detain this kid for a while, right? So that was when you do education with everybody, like, he doesn't know Ebola. And then telling me, like, I offer the families on either side of them, do you want to move? I know, P.S., he doesn't know Ebola, you know, pay attention, don't react, right? Also, I'm worth a lot more money than what he's saying. And then right, give him another space. But it was a time-sensitive thing, right? I had 8 hours before that DCR was coming, and I wanted the DCR to see this, right?
I think the hardest part is consistency. And so so even in our hospital, a lot of our units don't have set expectations or limits or thresholds of what behavior they will or will not allow. And they often allow different levels of behavior depending on how the patient or the family looks or acts. And so as a unit, having a core set of things that you values that your unit holds that you guys will all follow, and you guys will all hold all families and patients to the same expectation, really helps your job be easier for, like, hey, just while we're here, this is an expectation of ours that if you're going to do this, you do it in the privacy of your own room. Or if you're going to talk like this, like, be aware there's other families around. And it's setting not just what the core values are, but what you would ask of a family or a patient if they were to not follow those. Just so everyone's doing the same thing. And that's pretty hard to do, so you obviously can't cover every behavior in that. But kind of having a set thing of, like, because there's tons of different things that, like, I may allow that Laura may not allow. Or I could say, like, Laura taught me a huge lesson when I first started working on the unit. The kids were really annoying and stuff, and I wanted them to move. I just kind of physically wanted to be like, okay, you're going in here, and I'm closing the door, and I'm walking away. And Laura's like, I can't do that, hero. I can't move this kid, because I'm not as big as you. And so
Also,
you
I was
can't.
pregnant.
When
you get pregnant, you'll know.
You're working on it. But I need to make sure every intervention I do is something that any other nurse or coach or doctor or staff can do as well. I can't just manhandle kids and expect, like, all right, well, once I leave, hopefully they have someone who also can manhandle kids and do the same intervention with kids. I know that all of our interventions that we have our staff do, we try to make sure that it's universal that every staff can do. We have like 5 minutes left, 4 minutes left, so I feel like we continue with questions.
You guys
We'll
can have
send you the
slides.
slides.
Yeah.
Okay. Perfect.
Because I want to be able to hit your like what you guys personally. Unless you guys have no more questions.
Is the next slide to talk about interventions during the crisis phase?
Yeah, kind of. So we can go. Okay, we'll go through the slides. So in the crisis section, this can include unsafe behavior towards self, others, and the environment. Be prepared to manage safety. Whoa.
She moved it forward. I moved you along. Because their answer is on the next one.
Okay. Safety is our first and foremost concern in a crisis. Keep the environment clear of simulation. So this could be people and or items. So when things are unsafe, we want to pull people out of the situation as much as possible. You usually want to have one voice talking to a person, because it can get very confusing for someone if they're trying to convince two other people. You want to stay calm, slow down, keep your language short and simple, just a few words at a time. Understand that as someone's going through crisis and escalation, if I'm working with Erica and Erica's trying to throw a chair, that means she's really up close to the top. I'm probably also really close up to my top because I'm matching her escalation. I need to be aware of that so I'm not making any rash decisions. You need to have different expectations in a crisis. Being okay with a child playing a video game, eating ice cream if it means they put down the knife, pills, etc. We are not reinforcing bad behavior in a setting. So saying that just because we let a kid do a favorable activity to make the situation safe in this one instance, that was because our goal was to make sure this kid doesn't cut their wrist or doesn't cut their throat or something like that, or doesn't try and strangle themselves. We made the situation safe, because that's our number one priority always. It's not, I'm going to try and instill values in this kid while also trying to get them to not hurt themselves at the same time. Like, they're not going to learn at this stage. So we may do a one-time behavior that favors them to make it safe so that we can teach them the responsibility afterwards. We don't get into long-term issues, bring up past crisis situations. It's not our job to change their long-term bad coping strategies. So if we're ever talking to someone, they're like, man, you do this every single time. That never calms anyone down. They're not like, oh, I do this all the time. I should stop. Like, that's not how it happens. So knowing that if family members or other people are saying this, be like, hey, you know what? I'll handle the coaching. You go ahead and take a break yourself. You seem pretty stressed out. Why don't you go get a coffee, decaf, and we'll... Our interventions from least to most restrictive, starting at least restrictive at the top. It's kind of a dance of moving up and down this. So being aware of triggers is really helpful for avoiding getting into crisis situations in the first place. Building rapport is super important. People like listening to people they like. People don't like listening to strangers. Active listening is huge, so you're aware of what is going on with the patient, and knowing what is causing them pain or frustration. Validating the experiences of that. Playing with the patient, because we have kids at the Children's Hospital. But just interacting in a playful manner with people. Emotion coaching is really important of validating their feelings and their expectations. If you cannot make them feel better about the situation, you can always try and distract, whether it's with music or a movie or just different conversation, just changing the topic. We decrease anxiety with information. We model appropriate behaviors, set expectations without lecturing people. If we need to, we then come to reality checks, which is the like, we are in a hospital, this behavior is not appropriate right now. Real hard to do that with some people, sometimes it really backfires and doesn't work, but knowing when a reality check can or cannot hurt the situation.
So those are the ones that you can go up and down in, right, and dance through. Once you've exhausted those and you start setting limits, you're not going to go back up to playing an emotion coaching, right? Now you've set a limit on the behavior, not on the kid, on the behavior. Because you can have your feelings, but you can't throw the chair or get off the table. And then you wait for that limit to be met. And if it's not met, then you go to those last 4 bullet points, right? So space is how to give the semblance of space, even if you're in one room. So how do you give them, there's a study that talked about that people, when they're escalated, need 3 feet around them as a bubble. So how do you create that, maybe having just one more person in the room with you and everybody else outside of the room while you're keeping a visual, but you've set a limit and now you're verbally disengaging but visually engaged. So watch whether or not they're meeting that limit. And then how do you use lighting in the room or other objects in the room to give them more space in there, and then retreat physically but while keeping your eyes on. And then if that's not an option, you use and if that's not an option, then you retreat.
You guys have questions about this slide? It's pretty complicated. I'm serious. Like, if there's anything, like, how do you play with a patient that's 37 years old? Like, or motion coaching. All right. We're over.
I think just the one last thing I want to say about de-escalation is that it'll take kids 20, 30, 40 minutes to de-escalate, and that's a lot longer than all of us grown-ups want to wait for them. And so we get ourselves in trouble by not waiting for them to totally de-escalate and get back to baseline. And so that is a huge part of just managing ourselves, to really wait to, and it might be across shifts, right? If somebody has a escalation at 2:30 and I'm off at 3, then I'm gonna have to hand that off and trust that my coworker's gonna take that and resolve and problem solve for the next day. Or I might start my shift the next day of like, hey buddy, I left yesterday and you were having a really hard time, I want today to be better. How can we, tell me about what happened, you know, to bring it to problem solve in that moment, instead of just ignoring it and thinking it won't happen again because it's Tuesday and Tuesdays are good. But we'll send the slides out to all of you. Thank you. If anybody has
We have a lot of
burning
copies of the
questions,
safety ladder still here
yeah,
too. Okay, so-
take them if you want. And then the other resource, I know our hospitalists here have the availability of our site consult service, but I'm also happy if you give me a call during the week, and maybe I'll check my email on the weekends. If you have a really tough kid or need some behavior management help, I am happy to give phone consultation or figure out other strategies to help things go better. Yeah.
Can you send electronic versions of your handouts too?
Sure.
Thank you.
Yeah.